I also, if you think it's going to be awkward, when it goes deep, literally you have so many options available to you.
Right, take the time. Good morning. Good morning, everyone. Good morning, everyone. Let me call this meeting to order. I could swear Michael Cohen was not testifying here. Maybe I'm mistaken about it. Good morning. Welcome everyone to the meeting of the Market Oversight and Transparency Committee. Before we begin, I believe Ron was going to be on the phone because he's communicably ill, so be sparing the rest of us. Ron, are you there? There was a faint whisper. Ron, I assure you it's not our attempt to make sure that you can't hear us, or that we can't hear you. Can you say something again, Ron?
Yes, can you hear me now?
Now we can hear you, thank you very much. Ron, here as members of the committee are Barbara, myself, and Elizabeth, and then there's a spot for Rick Lord, who I think is just going to be a few minutes late. Very good. So the first item of business is we need to approve the minutes from our November meeting. The minutes have been distributed to the committee. Are there any suggestions of changes or other suggestions? Okay, is there a motion to approve the minutes? Oh, okay. Why don't we wait until Rick comes so we can get Rick's comments on them. So we will come back to the minutes. We have three items today. I was telling Barbara that we have to give out antihypertensive medications for at least two of the items on our list today, since they have the capacity to raise our blood pressure. The issue of out-of-network billing we're going to take up first. This is an issue that the Commission has thought about as a whole, which is what happens, the canonical examples when a patient goes to an emergency department and then receives a bill. The emergency department is in network, but the emergency physician is not, or the radiologist or the pathologist or a similar type physician. And so we'll have an update on what's going on in Massachusetts and around the country. Second is white and brown bagging, where the issue has come up before, and again, it's something that makes me reach for the aspirin. And we've been doing some work on it, so we'll get an update about that. And then something that's a little bit calmer, which is registration of provider organizations, but we will talk about the latest initiative. So those are the three items. David, do you want to make any general comments before we start? All right. So why don't we start off with the out-of-network billing?
Great. Good morning, everybody. I'm Kate McCann. Thank you, Dr. Cutler, for the introduction to the topic. Hopefully our hypertension will be in check. We haven't presented on this topic, we haven't focused on presentation on this topic in a bit of time, but as you say, the Commission has been thinking about out-of-network billing for some time. We first were thinking about it in connection with the 2015 cost trends report. In connection with that, we published a policy brief on out-of-network billing in 2016 that's still available on our website. And as you set up, Dr. Cutler, today's presentation offers a series of updates. There's a lot of activity in this space, and so we wanted to come back and provide some updates from Massachusetts, as well as from other states and on the federal level. So before we get into the updates, I'll do a little bit of background as a refresher, make sure everyone's on the same page about terminology and scope, but I will move fairly expeditiously since there are quite a few updates to be given. But please feel free to interrupt with questions if you have any, and we'll try and reserve some time for discussion at the end. So on this slide, I won't review verbatim, but this slide slide really outlines the scope of what we're talking about when we talk about out-of-network billing concerns. And Dr. Cutler teed this up exactly right. Patients may seek out-of-network care in a variety of circumstances, but concerns arise when patients receive out-of-network care that they did not or could not intentionally choose to receive. And that predominantly happens in two scenarios, the first being emergencies, and the second being out-of-network care that was received after going to an in-network facility. So after the patient, affirmatively chooses to go to an in-network facility, but during the course of provision of care while they were there, they received out-of-network care. This often happens with the ERAP providers, if you will, so emergency radiology, anesthesiology, pathology, some of those hospital-based physicians. And those two scenarios are really what we're focused on when we're talking about this. And those situations can have significant consequences, both from a consumer protection standpoint as well as have significant implications for the healthcare market. So just to hammer home two important terms, in those scenarios where inadvertent out-of-network care occurs, there's typically not an agreement between the provider and the insurer for an agreed upon negotiated payment rate. And so after services are rendered, the provider will bill for the services rendered, the insurer will typically pay something, and that delta, what's left between the charges and what the insurer paid, can come to the patient in some cases as what's called a balance bill. So the patient's liable for the delta there. Surprise bill is something specifically defined, and I just wanted to make sure we are all understanding what that term means. Surprise bill really results from that second inadvertent out-of-network care scenario that we talked about on the last slide. So after going to an in-network facility, the patient receives out-of-network care. They may not have even known that they received care from an out-of-network provider until they subsequently receive a surprise bill for those services. And this term gets used somewhat loosely in some of the conversations, but just wanted to set the table that when we use that term, this is what we're referencing. And there's a link there to the policy brief again for additional background, additional context. So before we get to the updates, this slide is just a reminder about the framework for thinking about comprehensive solutions to address this important policy area. And it's a lot of words on this slide, but the key takeaway is that each of these rows is really a category of solution, if you will. And as noted on the bottom, the states that are thought to have really most comprehensively addressed this have solutions that involve all three of these solutions. So they take different approaches to them, the details vary, but they work best in a complementary fashion. The first category of solution, if you will, is really aimed at reducing these scenarios, and not all of them can be avoided, but disclosure and transparency requirements can really increase access to timely and reliable information for consumers so that they can make the most informed decisions possible about in-network care, network status, and cost implications of receiving out-of-network care. The second category of solution is about removing the patient from the, quote, payment equation that results when these types of out-of-network care do happen. So hold harmless provisions and balanced billing prohibitions, which are subtly different concepts but work best together, take the patient out of the middle of the question here. So the patient's liability is limited, the provider cannot balance bill them on top of that, and then they're removed from the resulting question about what is the provider paid. And it's worth probably noting that really across the board, there is general consensus on this point, that in these inadvertent care scenarios where out-of-network care is received, the patient should be held harmless and limited to what their liability would be had that care been rendered by an in-network provider. And that when either an emergency or after electing to go to an in-network facility and receive out-of-network care, it really isn't fair for the patient to be subject to any additional liabilities beyond what they would have been in an in-network scenario. So there really is consensus on this point. And both of the first two buckets really speak to the consumer protection aspect of this policy issue. And there's really, I would say, broad consensus on that. By contrast, the third category of solution here has to do with what that out-of-network provider is paid. And this is a very important and complicated part of the policy question here. And there is not consensus on this point. This is really where states who are wrestling with this are, spend their time grappling with how to address this. It's a very complicated question that involves a balance of interest between the insurer and the provider. States generally have addressed it by either setting a payment standard and or by establishing a dispute resolution process pursuant to which that amount can be determined. So as you'll see, states take different particular approaches, but that's generally how it's addressed. And this is a very difficult piece of this yes.
I just want to make one comment on the last issue here, which is there's a solution that most economists like, but I don't think has been implemented, which is to, since a lot of these happen in the emergency department, just bundle the services for the facility just go and say, look, rather than having a separate bill for the emergency department and for the emergency physician, you're going to give to the hospital one bundle payment, and then you work out with the docs how you want to do it. So if you want them to be out of network, you've got to work out whatever payment you think is appropriate or in network. And so that way the Commonwealth would not have to set the rate at all. It would just come through whatever negotiation it was. And I think that would work for everything with the exception of ambulances. Because all the other providers are all inpatients and they're all associated with an institution. You then need, but the one that's not associated with an institution is the ambulance.
Would that be a payer-instituted reform, or something that would be dictated by the state's regulation or law?
The payer could do it on their own. So there's nothing that's preventing any of the payers from going to any of the providers and saying, instead of having, for emergency, or even for everything, instead of having separate physician fees, surgeon fees, radiologist fees from facilities, we should have one common. There's nothing that would prevent them from doing that. It is also the case that the state could play a role in encouraging them to do this by saying, look, this will solve this other problem right here. This is a very big problem for consumers.
I think that's right, Commissioner Cutler, and just to note that these solutions are ones that we found have actually been implemented, and that would have certainly been proposed. One complicating factor is that these ERAP providers are not always employed by the hospital, frequently are not.
So that's okay. All they need would be a contract. So they need a contract that says, look, if you're an EM physician in our emergency department, then here's the amount you'll receive. So they wouldn't have to be deployed, but it would absolutely force those two to have a contract. And it would sort of get the government out of the determination of what's a fair price. And it would say, you two, I don't care, you two figure out the fair price between the two of you. But that's how it's going to work.
Great, thank you, Commissioner Cutler. So are there any other questions on sort of framework or background or scope before we get into the updates? Okay, great. So the first update comes from right here at the Health Policy Commission. Just a reminder and a recap that in the 2018 cost trends report, which was just published this month, the Commission recommends strengthening existing out-of-network protections to comprehensively address this both for consumers and to address the market implications of this policy issue. So you see in the sub-bullets, the recommendation reiterated here. You will note that these really harken back to the categories of solutions we talked about on the previous slide and involved requiring additional notice in non-emergencies for patients, really explicitly prohibiting balance billing and making sure we're limiting cost sharing levels to in-network levels for consumers, and then tackling this reasonable and fair provider reimbursement question. The other update from Massachusetts comes from just up the hill, and just wanted to provide a refresher for everyone that in the last legislative session there was legislative activity on this front. Out-of-network billing was addressed in multiple legislative proposals, including in the comprehensive healthcare bills put forth in both the House and the Senate. Each of those took a multifaceted approach to this and involved, disclosure and transparency requirements. They both would have prohibited balance billing for patients, again, getting at those first two solutions. And then they each took a different approach, but they did address the question of out-of-network provider payment determination. There were some differences between them, including the example you see here, which is that the House bill established dispute resolution while the Senate bill did not. There were some other differences, but they both did address it. Conference committee did not result in a final negotiated compromise bill, so neither of those came to fruition. But certainly, we saw an increase in activity, and we will keep our eyes open as the legislative session really gets underway in 2019 and 20 for solutions that might address this.
I would just add, in the governor's budget, there is a proposal to extend balance billing protections as they apply to the group insurance commission. They currently apply only to indemnity plans, and so there is a proposal to extend it to all. So it's only a segment of the market, but I think it's important to keep an eye on this.
Thank you.
And I just have to ask, I'm sure the so I'm sure there's going to be another healthcare bill this session, right, coming out of the House and the Senate. And I know that the HPC won't probably be involved in lobbying, but we will be very involved with Friday in what this bill looks like, and really could use your assistance when it comes to these types, because it gets very technical, and so just looking forward to working with you as this debate resumes at a beginning.
Yeah, and the one thing I would just add on that, Commissioner, is our cost trend supports recommendation lay out the important areas that need to be addressed, but the recommendation did not have a very specific, and this is what fair and reasonable reimbursement should look like, but that it should be included. And there, as we're going to hear, many different ways of doing that, and it does get quite technical.
Wonderful. So moving outside of Massachusetts, you can see from the amount of text on this slide that there are a lot of updates from other states. There's really has been an uptick in activity in this policy space. So on the top of the slide, we talk about some states that have recently passed or implemented or amended their out-of-network billing laws. A handful of them did so in the last year or two. Jack Holdley and his group at the Commonwealth Fund sort of updated their research on this in January, and they now say that 50% of states, including Massachusetts, of course, have at least partial protections in place. So there really is some momentum on this policy topic. Two states highlighted here, and you could talk about all of them in great detail, but I'll highlight two. The first one is New Jersey, and you may recall that New Jersey was spotlighted in the HBC policy brief on out-of-network billing as an illustration of really the importance of taking a comprehensive approach to addressing this. In New Jersey, consumers have been protected for quite some time and they're held harmless, but insurers were paying full charges, or they could litigate the charges, but it had significant consequences for overall spending. And so for many years in New Jersey, the legislature had been trying to pass a further solution to this problem. There was a new administration in New Jersey last year. There was sort of a renewed push to get this done, and they did pass a law in 2018 that strengthened the existing protections for both out-of-network emergencies and non-emergencies. There are many pieces to that law. For example, it included new disclosure and transparency requirements, but the key fix was establishing a claims processing and arbitration system. So insurers and providers who couldn't reach agreement on payment after a certain amount of time negotiating can initiate binding baseball-style arbitration if there's at least $1,000 delta between their final offers. And just a quick second on what baseball-style arbitration means. I think it's called that because it's used in player contract negotiations a lot in Major League Baseball, but it basically requires a final offer from both parties, and the arbitrator selects one of those final offers as the final number. So they're not coming up with their own independent, reasonable dollar amount. You pick one of the two sides, and that's important because the theory is that induces both sides to be moderate. Because as a provider, your final offer is really high, or as the insurer, your final offer is really low, you're going to lose. So that's the theory, and that's what New Jersey has set up. Other states have taken this approach as well. What's also unique about New Jersey is that the law provides an opt-in for self-insured plans to be subject to the claims processing and arbitration process provisions. A very important contextual note that we will revisit on the next slide as well is that everything we're talking about in terms of state level protection exemptions applies only to the fully insured market because of ERISA preemption. And you see the importance of that reflected in this opt-in that New Jersey has crafted in their law, saying that self-insured plans can elect to do this to protect their patients and address this question. So that's interesting. We haven't really seen that before, and the mechanics of the arbitration work a little bit differently depending on whether your self-insured plan is opted in or not. There are some calls in New Jersey to amend this law already and sort of make some clarifications and make some improvements. So we'll see what happens there. The other state that's highlighted here is Oregon, and Oregon had been working on this for some time in their legislature. In 2017, they did finally pass a law. The legislature had been considering, I think they were down to 2 specific approaches on provider payment determination. They ultimately sort of stripped down the bill and passed it into law with the consumer protection piece in place. So the balanced billing prohibition was passed. But the law delegated the whole question of provider payment determination to a state agency. That agency convened an advisory working group that was multi-stakeholder, including providers and payers and consumer groups. That group met several times and also did not reach consensus on this question. And so in the sort of 11th hour before full implementation of this law went into place, my understanding is insurers and providers ultimately agreed on a payment level that was memorialized in an amendment to the law, I think ushered by the Senate Health Committee. You see the payment standard that they picked there in the parentheses. So there was at least, clear direction on what the providers would be paid. From what I've read, it doesn't seem like anyone is particularly happy with it, so you can maybe expect to see it, advocacy to pull it in any number of directions in the future. But the reason Oregon is spotlighted here is because I think it really illustrates the complicated nature of this, piece of the equation, both how important it is and both how challenging it can be, even with all the parties at the table. And so in terms of what to watch for, we definitely expect to see efforts to address this or amend billing laws that are already on the books in many states, and there are a handful of them cited here. All of those states either have bills that are working their way through the legislative process, or the administration has identified it as a policy priority area, or individual legislators have, or the insurance commissioner in some cases. And just an interesting note from Nevada, you can sort of see their multifaceted approach to this. The new governor there campaigned in the fall. His healthcare platform included out-of-network emergency billing protections. They are also expecting new legislation to be introduced that's been based on basically year-long working group efforts with one of the Democratic assemblymen. And then vetoed legislation from the last session is, I've read, is expected to be reintroduced. It was vetoed by the former governor over the question of provider payment determination. He felt that it would have significant implications for the provider supply market, basically, and could even lead to some access issues in Nevada. So he vetoed that, but it sounds like it might get reintroduced and could potentially be overridden by the legislature. And then uniquely, they have a state constitutional amendment in the works that also addresses this in some fashion. So they're really trying to come at it from a lot of different ways. So lots of activity on the state level, and our last slide is about updates from the federal level. And that reminder about ERISA preemption is at the top of the slide. It is really thought that a comprehensive solution to this policy issue requires federal legislation so that the self-insured market is protected as well. So in terms of takeaways from last year, there were several legislative proposals in the 115th Congress. One in particular that received a lot of press last fall was a bill that was introduced by Senator Maggie Hassan from New Hampshire. That would have established, it would have protected consumers, hold them harmless, prohibit balanced billing. It would also have established binding baseball-style arbitration. It also provides alternatives for states such that they could either establish their own arbitration system, as long as it's at least as protected as this one. And just a note that this bill would require the arbitration results to be public, which is kind of an additional transparency lever on top of it. Or they could set a payment standard, and there are some specifics around what that would need to be. Another bill that received a lot of attention and is continuing to receive a lot of attention was a draft bill that was released in the fall, led by a bipartisan group of 6 senators, including Senator Bill Cassidy. This takes a different approach to out-of-network provider payment determination. This would have set the out-of-network payment standard. It's a bit of a mouthful. You can see it in the middle of the screen, but it would essentially say, the out-of-network provider will be paid in accordance with a state law, if there is one that's applicable, or if no such law exists, it sets it at least equal to the greater of the average amount, or the UCR, the usual, customary, and reasonable, and both of those terms are defined. So even here you see two different approaches. My understanding is that Senator Hassan and Senator Cassidy are both sort of refining their approach and recommendations and working together, and the Cassidy bill was just a draft bill, so we'll certainly look for a formal introduction soon on that. There was also a real uptick in industry coalitions forming on this for advocacy. The lobbying efforts increased. We see letters to Congress from lots of different groups, including the hospital industry. There was a coalition formed in late 2018 that was sort of insurer and retail and consumer based. Lots of groups coming together with ideas about how to address this. Definitely see an uptick in all of that action. And media coverage, as it has been for a few years, has really increased as well. So what to watch for? We'll certainly keep an eye out for legislative proposals. There's been a lot of talk that there's promise for bipartisan reform here potentially. Keep an eye out for a Senator Cassidy-led bill and/or modifications from Senator Hassan. Representative Lloyd Doggett already introduced a bill in late January for this session, which he's done, I think, 3 consecutive sessions in a row. And we'll look for continued input from the industry stakeholders. Senator Cassidy sent an information request to major industry groups, asking for some data and their input. And finally, in January, there was a White House healthcare roundtable, and President Trump sort of declared that the administration would end surprise billing. Haven't seen any specific policy proposals from Secretary Azar or otherwise, but we'll certainly keep an eye out for that. And I think all of this just really underscores that it's a pressing policy topic. Lots of people are thinking about it. There are lots of ways to address it, and many people are willing to come to the table to really wrestle with this and come up with a solution. So happy to take questions on any of it, and turn it over to you, Commissioner Cutler, for discussion with what time we have left. But it's a lot of information, so happy to take questions too.
Let me open it up for comments from the committee.
Just so you know, how many, or have, in New Jersey, has anyone taken advantage of the self-insured plans?
I don't know yet. It's still pretty new in New Jersey, and they're still rolling out kind of specifics on implementation. So I don't know yet.
Ron, let me give you a chance to jump in if you want to.
Okay, thanks.
You want to jump in now? Do you want to wait a little bit? Do you have any thoughts you want to add?
No, I'll wait, thank you.
Okay. I want to come back to where we are in Massachusetts and what more the HPC can do. In the drafts of the bills last year that were in Massachusetts, can you just review what they had just one more time for us, please?
Sure. So both bills, like I had said, took sort of a multifaceted approach. They both included disclosure and transparency requirements. As it says, the extent and details of which varied. As I recall, the House bill had much more extensive transparency and disclosure requirements, and these can be for carriers, individual healthcare professionals, and or facilities. They both prohibited balance billing and would hold consumer cost sharing to in-network levels. The real substantive difference between them was on their approach to provider payment, and I'm happy to sort of sketch out what those differences were. They both, if you can think of sort of a 2x2 grid, where on the top you have out-of-network emergency services and out-of-network non-emergency services, and on the other axis of the grid you have provider contracting status. So bills thought about whether that out-of-network provider in a particular circumstance was contracted with that particular insurer at all. So certainly if we're talking about out-of-network care, they weren't contracted for that patient's particular plan or product, but are they contracted with that carrier at all for at least one other product? And so that contracting status was on sort of the other axis. And in the Senate bill, for example, they established payment rates, out-of-network payment rates in each of those four resulting buckets. In the case where the provider was contracted otherwise with the carrier, the payment rate would be the in-network contracted rate. And it wasn't totally clear on how it's determined if there was more than one other in-network contracted rate for those two parties, but it was the in-network contracted rate. The Senate bill then would have established a non-contracted commercial rate for emergency services or non-emergency services. And in the Senate bill, that had kind of a phased approach. It would have established an interim rate right away, where that non-contracted rate would have been defined as not more than the 80th percentile of charges based on a benchmarking database, an independent benchmarking database. It didn't specify which one. And then that would have sunset at the end of 2019, and in 2020, the Health Policy Commission would have been charged with setting those rates for a term of 5 years, I think. So that's how the Senate, tackled that. The House similarly thought about this network contracting status. They didn't distinguish between contract status on the non-emergency side, but they also had the in-network contracted rate for part of the payment determination, and then they set it particularly. I think it was greater of 115% of the average contracted rate or 125% of Medicare.
This only applied to purchased insurance. It did not apply to the self-insured, or did it?
It would not have applied to self-insured.
Is there anything that we could recommend the Commonwealth do that would apply to the self-insured population?
One of the aspects, and correct me if I'm wrong, Kate, but the prohibition on balance billing can apply to the providers. So that's where there is leverage for the state, both in sort of licensure and regulation of hospitals as well as individual clinicians. So there can be a mandate that prohibits balance billing to the patient. The question is mandating payment on the other side, and there are ways in which we can think about that, but ERISA preemption does present a barrier.
So you can dictate balance billing protections, but you cannot dictate the default payment.
Unless there's sort of we could do as Kate was trying an opt-in or
Voluntary.
potentially an opt-out.
So we could make the future legislature knows about this. Could we get information on which institutions have out-of-network providers for these services? Could we publicize that?
If I'm understanding your question, I think the answer is yes. I think even, for example, in 2017 we presented some research from the APCD that addressed potential prevalence of these issues, and if I'm not mistaken, looking at my RPO colleagues, we said that I think on average ER services are sort of outsourced 2/3 of the time, and in Massachusetts RPO data shows it's about 1/3. So that's an example of some information
Well,
we could get.
we could actually publish names. Putnam Memorial Hospital is using out-of-network emergency physicians. Shame on them.
Well, as we understand it, there are circumstances where hospitals have to rely on some of these kind of contracted emergency physicians in order to staff their emergency departments. That hiring emergency physicians into these hospitals is a real challenge, and so
And it's often a decision of there's two issues. There's the contracting of the company, and then does the company choose to be out-of-network?
Sure.
And there are some EM staffing companies that are almost exclusively out-of-network, and there are some that are almost exclusively in-network. And I presume that the hospital knows when it's hiring whether they will be out-of-network or in-network. And since they've made that choice, we should
I think we could, yes. And certainly, we know that in some of the national literature, there are known for profit chains of doctors that are highly prevalent in out of network billing situations. One thing I would add from the data analysis that we conducted on the claims data, now 2 years ago, and I think one of the things we understand in this market is that in many circumstances the health plan is paying for that out of network bill and is holding their member harmless. Now that is good from a member standpoint, but what that does mean is that in many cases the payer is paying charges. So it is paying that supra rate of payment to the hospital, which inevitably leads to higher premiums for all of us who are paying our health insurance. And we also know of many circumstances where, again, insurance companies may hold their member harmless in a surprise billing situation, but only if the member goes and appeals that to the insurance company and kind of presses the point. And so, again, that relies on kind of the proactive advocacy of an individual patient who may not even know about their rights and their ability to do so to be able to access that type of protection. So part of what these laws are trying to do is to create standards that apply in all circumstances and kind of get the patient out of it. The one thing I just also wanted to add, and then a question for Kate, was in terms of the ERISA and kind of the exemption, the kind of the proactive transparency and consent provisions would presumably apply in all circumstances. So those can be requirements of the provider or the facility in the same way that you can make a provider or facility not prohibit them from balance billing. You may require them to, in all circumstances, provide that type of informed disclosure, regardless of if that member or patient is in a self-insured plan or in a fully insured plan. But again, to your point, Commissioner Denniston, issues of prescribing a default payment rate are trickier. Kate, I wonder if you can share with us, what do we know about how any of these laws are working? Do we have any evidence that they're actually prohibiting some of these circumstances, and particularly in the cases of where states have set up these arbitration type processes, how often are those being availed of?
Sure. So, sort of, caveat at the beginning that a lot of these laws are still new, and information like that would be very helpful is not always publicly available. However, there are a few anecdotes that I can offer from a few states. First is Texas. Texas has a mediation program in place for these issues that is now turning 10. They've amended it twice. It has been used increasingly. I think in the first year they had a few hundred requests for mediation, and this year they're expecting 8,000. So it certainly does protect the patient, but reflecting back on what David just said, it requires that the patient know about this, that they got a balance bill, that there's this mediation program they can utilize, and oftentimes it doesn't go to full mediation, it gets settled in informal teleconference. So that's good. So those are encouraging numbers out of Texas. However, they are still trying to reform it such that they just prohibit balance billing, protect the consumer, take the consumer out of it, and the insurer and the provider figure it out. So, not clear that the mediation program is really the best approach altogether, although it seems to be having increasing success. In New York is sort of thought to be the first really comprehensive law that was passed, and they passed it in 2015. They have an arbitration provision as part of their law. New York does not affirmatively cap the rates, but requires reasonable reimbursement by the insurer, and then they need to reveal their methodology for calculating it and say how it compares to the 80th percent based on a benchmark. And there is an arbitration process. Some anecdotal evidence that we've heard out of New York is that by and large it seems to be working. The patient is protected, and the arbitration process is sort of accomplishing its goals. My understanding is that some of the time the insurer wins and some of the time the provider wins, and don't have detailed statistics off the top of my head, but they're a few years in, and that that seems to be effectuating its purpose. Did you have a question on that?
If you're done,
I'll offer one more. Thank you. And then a little bit different in California, and these are anecdotes, but California's law, implemented in 2017. California takes a little bit of a different approach. They set the payment rate at the greater of the average contracted rate, or 125% of Medicare. And just this past fall, there's a RAND researcher who did a poster session on stakeholder interviews from early implementation and kind of early thoughts. And one of the takeaways from that research was that the providers were saying that the law, while very well intentioned and intended to protect consumers, is in fact doing that. It is protecting consumers. However, the provider stakeholders claim that it really shifted the balance of power to the insurers, and the insurers are now saying, effectively, oh, if you don't want to negotiate and come in network and contract with us, we'll just pay you the rate in the law. And the providers are saying that that's very low, and that they are having to think about forced consolidation, and there's been higher failure to contract rates, and so they're calling for immediate claims to sort of address the rate and adjust it such that it's sustainable, and that they say, well, this law protects consumers. If it really causes a provider access issue or provider supply issue, that can cause an access problem, and that's harmful to consumers in the end. So that's early evidence from implementation there. It's anecdotal, but an anesthesiologist who wrote an op-ed about this also said similar things, that our 100 anesthesiologist practice went to contract. We've had a good relationship with this insurer. They basically asked us to cut our rates 40%. We couldn't contract, and they said sort of, okay, well, we'll just pay you the default rates in this law. So those are 3 anecdotes. I think it's still early in general, but it is important to think about how it's affecting the market, and does it need adjustment, because it's this really important question of addressing something that the market hasn't really.
I have an observation and then one question on those 3 anecdotes. I think one other limitation of state regulation that's important to highlight, which I actually learned from my own personal balance billing experience, is that we can only regulate in-state providers. So to the extent they're exporting to out-of-state providers, those balance billing protections won't attach. And my question is whether, so you spoke to it kind of indirectly, what is the more effective consumer protection, the kind of default provider rate, or this kind of arbitration mechanism? And it doesn't sound like there's a clear answer.
So just to make sure I understand, what's the better consumer protection?
Right. I guess in both cases you could just outlaw balance billing,
Right.
and they both have perfect. Yes. Then the payer provider would enforce the rates across the consumer.
Yes.
I guess, what would you see as the better of the 2 policy solutions based on what you just said?
Well, I don't think there's a clear answer. I mean, there are sort of advantages and disadvantages potentially to both approaches. Arbitration, for example, is more administratively involved and complex and can be costly. Setting an out-of-network payment standard is more clear in theory if it's.
Yeah, but shifts balance of power.
It's potentially. I mean, there it is. This is one of the reasons it's so complicated, because you are, there's a risk of setting it too high. There's a risk of setting it too low. It really impacts the healthcare market as a whole, and that can, of course, always come back to the consumer in the end. So it's an extremely complicated question, and I think the states we've talked about and others really illustrate that there isn't a silver bullet here, and there are local market considerations potentially at play as well. But not clear that one's better. I think there are advantages and disadvantages to both, and really the states are tackling this or trying to be mindful of the consequences and potentially unintended consequences of addressing that.
That's sort of why the economic solution is to force the providers
That's
to
a
bargain
really good
together,
point.
because, as Kate said, who the heck knows? I'm in no position to determine whether 115% or 123% is a better number, but I can leave it to the hospital and the EM group to say what's the right way to split this. Other comments?
Jinx is the mic.
There you go.
Okay, thank you. And I guess this is a question for David. And I'm thinking again for the legislative process somewhere down the road. There's likely to be comprehensive comprehensive healthcare reform bills coming out of both branches. This topic will be addressed. Does it make sense? And we have new healthcare chairs and probably a lot of new staff, so not a lot of expertise and knowledge about this issue. Does it make sense for the HPC, and I know we're not big today, but to come up with a recommendation rather than to react to what ends up on the floor, and to make a recommendation about what we think is the best approach? I think my guess is they'd welcome that, given how complex this is and all the different alternatives. So that's just a question.
Yeah, so definitely look forward to engaging with the new healthcare financing chairs. I would say that there are a number of staff members who are in the room representing those offices and staff that were part of the negotiation process last year who I think will continue on. And so I think there is some institutional knowledge on these issues. I think we definitely have a recommendation that we, and a strong sense from this commission over multiple years, that this really does require a comprehensive solution. I think the one place where we have not yet made a very specific recommendation is what exactly should that third lever be in terms of what is the best approach for the kind of the payment default question. Whether it is set at something, what is it set at? Is it the greater of 3 different things or the lesser of 3 different things, or some type of arbitration process, which in some respects kind of also speaks to your point, Professor Cutler, of like let the provider and the health plan negotiate it out, and if they're reasonable, maybe they can come up with a reasonable rate, and it's not necessarily the government saying this is the default rate. But I don't know that we've as Kate just said, I don't know that we have yet kind of said this is the right way to do that third thing, and recognizing that there are different ways to do it. So I think it's an open question for the commission, and one that we're certainly want to provide as much information as we can, and potentially provide information about what those different thresholds may mean. So one of the things that we did do in the cost trends report this year was compare commercial rates to Medicare rates, and so one could imagine that we would be able to say, okay, well, what does 125 of Medicare look like, and to be able to provide some data for that. So it's not a direct answer, but I think it's one that we would hope to provide as much information as we can.
Thank you, Kate. Thank you. We should ask if you have any prescriptions to give us or any comments.
I think the discussion just reinforces the fact that there's a lot of complexity, a lot of ways in which consumers and providers can get confused. And with the ever-changing ground under us in terms of trying to continue with the facts, it's challenging for even experts to understand. So how in the world are consumers supposed to stay on top of this? Anything that we can do that will help simplify the aspects in which consumers are engaged, I think is an incredibly important thing to do. And whatever we can do in our world, in our sphere of influence, I think we need to do it. I'm learning a great deal. Thank you for the opportunity.
And I would say, Commissioner, you've very appropriately teed up our next topic of conversation. If you thought out-of-network billing was complicated and confusing for patients and providers, wait until you get to white bagging and brown bagging. So
Bring me my Remicade. But before Remicade, let's do a quick vote on the minutes from the previous meeting. Is there a motion to approve the minutes?
So moved.
Any seconds? All those in favor? Any opposition? Okay, the minutes are approved. We will now turn to Remicade. I think.
Hello, well, with that great introduction, I look forward to confusing everyone, raising everyone's blood pressure as efficiently and expeditiously as possible. So,
this is Sarah Sadanic, the Deputy Director for our Research and Cost Trends team.
I do look forward to presenting our findings today from our report that we've been developing on the alternative practice
third-party specialty pharmacies for drugs that a clinician administers. We have worked on this topic for over a year. This was from a legislative mandate. So we particularly look forward to sharing our analysis in key areas and our considerations for recommendations, and look forward to a discussion to further inform our recommendations and move us towards completion of the report. So what I'll go over today is an overview of the topic, and spend some good time there given the complexity of this topic, and then move through our findings on the prevalence of these practices, what these look like in Massachusetts, and importantly, the impact of these policies on healthcare spending, on safety and access, and then what's happening at the state and federal level, and finally our conditions for recommendations. So starting with what are we talking about? What are these practices? So this chart here illustrates the traditional model, the way things are traditionally done, which are known as buy and bill. In this model, the hospital or the clinic is the center of the model. The hospital buys drugs and stores them for general use. This flow chart has arrows for the flow of the drugs, the product, and the dash line for payment. So they buy and store the drugs for general use, and then when a patient requires a certain drug, they administer that to the patient. They then bill the payer for the drug. So there's that buy and bill. The payer reimburses the provider both for the drug and for the administration. The patient pays their cost sharing. So one very important point in this diagram is that is the price for that drug. This is negotiated between the payer and the provider on a contract basis, like any other service that the provider would provide. Okay, so let's talk about the alternative practices here. So, which we've sort of called colloquially white and brown bagging. So in these models that are disrupting the traditional model, the payers essentially remove the hospitals from those central functions, and instead use a third-party specialty pharmacy for both ordering the drugs, and the reimbursement goes to that specialty pharmacy. So there's often questions of what are we talking about? What is a third-party specialty pharmacy? So this is a different type of thing than the retail pharmacy that we all use. So some people do have experiences with specialty pharmacies. These are most people's kind of personal experiences with these are for drugs that are sort of complex, expensive, but are self-administered. So perhaps for fertility medicine, perhaps for rheumatoid arthritis, or other medications that patients take home and inject themselves. They may have personal interaction. So this model is unique in using these specialty pharmacies for the hospital services. So starting with brown bagging on the kind of red arrows on the left. So in this case, the third-party pharmacy orders the drugs and sends them to the patient themselves. The patient then is responsible for transporting that drug to the hospital or clinic for the clinician to inject or infuse the drug to the patient. So the term brown bagging comes from that visual of imagining a patient bringing a sensitive, high-cost drug in a brown paper lunch bag. White bagging on the other side, in the yellow arrows, is where that third-party pharmacy acquires the drug, sends it to the hospital's pharmacy that sort of stores it for the patient, and then the provider administers the drug to the patient. Again, in this case, the payment goes not to the provider. The payment for the drug goes not to the hospital or doctor's office, but to the
pharmacy, and the provider is reimbursed only for the labor of administering the drug. Patient pays their cost sharing again to the payer. Now, some important points here: when that function is moved from the hospital to the third party, the hospital or physician office loses that revenue stream. It loses the margin from buying and billing for the drugs, and this is widely known to typically be a very high margin revenue stream, revenue service line. Also, the price, the drug price, is not determined, sort of on that individual basis. But now this is similar to any other drugs that you might have at a pharmacy. These are these, through the PBMs, through these kind of big pharmacies. These are national contracts. These are kind of nationally negotiated prices. And in the next section, we'll talk about our findings on what those differences in prices look like. And again, patients may face a different type of cost sharing depending on, sort of those systems. Okay, any questions? Great, we're doing great. Okay, so the outline of our report, wanted to kind of share that to orient you. This is similar to what will be presented today, particularly balancing findings of financial safety and access. Okay, so overall, this is an important and complicated topic. We started with the literature. There is very little information on the prevalence of white and brown bagging in the United States overall, let alone in Massachusetts. There is comparison of some prices for drugs in the U.S. level, but really little information on safety and access at all, and no Massachusetts-specific information. So we supplemented literature instead with public listening session, sought written testimony, analyzed data from the All-Payer Claims Database, which I'll present shortly, and then conducted a survey of commercial payers in Massachusetts. We did not include national payers in this survey, but the respondents that we have represent about 3/4 of commercial lives in Massachusetts. And then we further supplemented that by searching publicly available documents. Okay, so what have we found on prevalence and what does this look like in Massachusetts? So in the U.S. overall, white bagging has become increasingly widespread in recent years, while brown bagging does remain relatively uncommon, it appears. So based on a fairly recent survey, about 9% of drugs in the hospital outpatient department setting were supplied for white bagging, compared to about 1% through brown bagging, and those numbers were quite a bit higher in the smaller provider setting, physician offices. In terms of Massachusetts, based on our survey and supplemental search, most payers allow the option for white bagging, brown bagging, and home infusion. And I should have mentioned this earlier. We also looked at, in addition to sort of pure white bagging and brown bagging, home infusion and practices of, in particular, kind of mandated home infusion, which are very closely related to these ideas. So most payers allow the option of that. 2 payers required white bagging for certain drugs. These are different drugs by different payers. Some payers required home infusion for certain drugs, and no payers that we could identify required brown bagging. So overall, this is about a few thousand patients receiving white bagging, and quite a bit higher number for home infusion, although it may not be mandated.
So can I just ask a technical question? Home infusion, is that when, does a provider go into the home to administer the drugs? So it's not a person that's doing it themselves?
Correct, exactly. Yeah, thank you for that question, it's very important. Okay, so importantly, we looked at what are the exceptions processes, because this is a really important part of it speaks to the options for patients if the patient or the provider doesn't believe that these methods are best for them. So there was a great variation in both the policies and the exceptions among payers that required white bagging or home infusion. for the mandated home infusion, payers only allowed exceptions if medical necessity criteria were met. Tufts did not allow exceptions to its policy for white bagging. The third party that they used a CVS Caremark. Blue Cross Blue Shield had a particularly interesting model for their white bagging policy, which is that they offer a site neutral payment policy to providers. In this case, essentially the provider agrees to accept the for all intents and purposes lower sort of third party price, but their operations continue essentially as they were before, alleviating their kind of safety and access concerns. It's the same system but accepting the lower price for that drug. Still keeping that revenue stream. Yes.
Are there any restrictions with regards to how the medication goes from the pharmacy to the patient's home? I'm thinking specifically of can drugs be mailed or do drugs have to be picked up? I'm thinking especially about homebound patients and the implications of that.
It's a good question. I'm not sure that detail had not come up in the case of brown bagging.
And the second question in line with that is that some home infusions, for example, I'm thinking, and I don't know if this falls under the criteria of home dialysis, where patients do it themselves, or family members do it, or for hospice patients at home where family members are giving fairly strong narcotics. How does that play with any of that?
I think that this speaks to a larger topic that we'll get to shortly about sort of differences in patient preferences for home infusion, and why that might be beneficial for some patients but not beneficial for other patients. Okay. So let's start with our findings on the cost side of things. So just running through methods, we looked at differences in prices in both the commercial payers and in Medicare. For commercial, we based our analysis. We were only able to base it on Blue Cross Blue Shield results, which was the only payer with a sort of robust enough sample size in 2015 for drugs in both the medical and pharmacy side for the drugs that we looked at. Important for interpretation to note that their site neutral payment went into effect in the fourth quarter of 2015. So this doesn't include rebates, and we analyzed the price per unit for free drugs that are sort of known to be subject to this policy. In Medicare, it's not claims, but it's fee schedules and publicly available information using a representative Part D plan, and then fee schedule on the Part B side. Again, not including rebates. Okay, so starting with commercial, we found that drug prices were indeed substantially lower with white bagging, ranging on a per unit basis for the three drugs we looked at from 15% lower for Remicade to 38% lower for Xgeva. In 2013, results were similar in 2015, although slightly narrowed. On the cost sharing side, I think in Massachusetts we found on average cost sharing was relatively low in both cases. So the highest cost sharing was $42 under white bagging, but the difference between the two is relatively small. So ranging with $12 higher per unit for Botox under white bagging to $2 less per unit under white bagging for Xgeva. So while the average cost sharing was low under both white bagging and buy and bill, the distributions of cost sharing were different, and we found that some consumers faced high cost sharing under buy and bill, likely reflecting whether they met their medical deductible or not. So, while under buy and bill, 91% of patients had $0 cost sharing. This is per unit of Remicade. There was a tail of patients with very high cost sharing, 3% between $100 and $500, and some small share even more. In contrast, on white bagging, most patients had some cost sharing, but it's relatively low amounts, and almost no patients at all had anything more than $30.
This is for a single bill, not for a year's worth.
Correct.
Might be interesting just to see what a year's worth, or so it's,
So it's a good point, and I think that does speak to cost sharing adds up, and the burden on patients opens the door. So and also I just want to reiterate that this is one payer, this is Blue Cross Blue Shield, and the total patient cost sharing really depends a lot on the price of the drug and on the benefit design. So I don't want us to sort of be lulled into thinking that there's not a problem with patient cost sharing for drugs. Okay, so
Elizabeth, did you want to?
Getting back to slide 27, it does seem like buy and bill versus white bagging, there's higher cost share for white bagging.
that
And I don't quite understand how it squares with slide 28.
that is true that it's in more cases slightly higher. The average is slightly higher with white bagging, but that average reflects that most patients with white bagging have some cost sharing, and the vast majority of patients with buy and bill have none, but a small tail has a very high amount of cost sharing. Most likely, yes.
Yeah, I think the important point here is that patients, depending on which kind of distribution channel this goes through, the patient's cost sharing can change. It can be something on one hand under buy and bill that need to be under their medical benefit, and so it's if you had an inpatient visit and whatever your copay was for that inpatient visit, and then they covered certain things and included there. Whereas with your pharmacy, you may have a tiered copay, you might have a specialty pharmacy, and so the copay per unit of drug on the pharmacy benefit may be different than if it's kind of in your medical benefit of going to a hospital or going to a doctor's office and a visit. And so
This just reflects the structure of the payment as opposed to the payer capturing a greater amount of savings.
Yep.
And the picture gets even more complex on the Medicare side. This is for 2018. So Medicare prices don't appear, they appear higher with Part D, the pharmacy benefit, compared to Part B, the medical benefit, but we know that rebates are not included here, and we know that's a major part of the story, and sort of even different than commercial plans, rebates are not kind of a big part of the story on Part B, and they're a major part of the story on Part D. So this is the most kind of grains of salt results that I can possibly present. So the patient cost sharing is a really different story depending on which drug you're looking at and the price of the drug. So from 5% lower with white bagging for one drug, sandostatin, compared to 113% higher for a different drug, for Gamagard. So this really speaks to not only is there sort of a high potential overall for greater cost sharing for under white bagging for Medicare beneficiaries, but sort of this policy really requires understanding what happens with the particular patients. Particular patient experience really depends a lot on their plan. I'm gonna kind of skip the summaries here, but just noting that our results in Massachusetts were quite similar to national estimates on the commercial side. are substantially lower with white bagging and returning to what happens with safety and access is a critical part of the story. So our findings here are synthesized from listening sessions and testimony and other kind of supplemental sources. On brown bagging, this is again where the drugs are directly shipped to the patient, or perhaps they are required to pick it up and bring it to the doctor. Provider testimony was quite unanimous in detailing safety and access concerns. Numerous safety concerns stemming from the requirements that a patient bring a very sensitive drug around. One comment about temperature swings in New England alone are enough to compromise the efficacy of many specialty medications. Really stood out to me, given the weather this week. It could be 55 degrees, it could be in sleep. So turning to home infusion and
the specialty pharmacies are probably very good at getting the temperature controlled drug to the patient's house.
that's right.
Right? They're probably quite good at making sure that the Remicade shows up on my doorstep and is in fact being controlled the whole way.
That would be
What
the
they're probably less good at is then, do I need it on the kitchen counter?
It then becomes the patient's
It then
responsibility.
becomes the patient's responsibility to do that.
Exactly.
And from then when that patient brings that drug to the provider to have it administered or infused or injected, that provider may not know exactly what happened along the way.
But it probably got to my house, my apartment, whatever, okay.
The expectation is that a specialty pharmacy would have the competency to safely deliver that drug.
No, that's right. Then there's all what I then do with it.
Okay, so home infusion, and then picking up on your earlier comments, Commissioner. Some providers and patients have raised safety concerns with home infusion, while others support the option of home infusion. For example, in pediatrics, a child may prefer a home environment that's less, more comforting than a hospital environment, or the opposite. Perhaps perhaps it is, emotionally upsetting to have this procedure done in your home. There's some literature that infusion can be done safely in the home, although these are very limited studies. And provider safety concerns generally focused on lower level of expertise and resources in a home setting. One patient testimony, starting, it only took my first visit to realize this option wasn't for me. Again, detailing an experience that stemmed from the level of expertise and resources and what was actually delivered versus what was expected. I don't know if those comments captured your question, or if you want to look at other questions.
It did a bit, but when I think about when we first started to have medications delivered directly to patients' home, as I recall, part of the issue was visiting nurses with narcotics in their bags, bringing those medications or other medications, and having that become widely known in the community, and having public health nurses who used to be very safe in any environment all of a sudden became individuals with drugs. And the result of that was visiting nurse associations asking that patients store those medications in their homes so that the nurses weren't going to be attacked to get the medication. And that's the very first experience that I recall of having that happen. But the issue of how do you protect the consumer in their home from exactly the scenario that's described here, and yet make sure that the care that's provided in that home meets the level that's needed for any possible drug reaction complications or mistakes that are made that have to be picked up. This consumer picked up those mistakes. What if they hadn't? And so the question is it only for a provider in the home? And if not, then how does the patient or the caregiver in the home develop the degree of expertise so that that experience is as safe as it possibly can be, given the fact it's not
many providers express concerns, but some providers also detailed safeguards that they use to successfully manage use of white bagging in their practices. I just wanted to note some of the safety concerns that providers mentioned associated with white bagging. The drugs can be incompatible with in-house equipment. The one, the connection between the packaging of the drug and the IV may not be compatible, and the provider is then forced to figure out a solution in real time for that. The provider loses control over which specific formulation of the drug. Same active ingredients, but different formulations may have different side effects for patients. Providers don't have that relationship with specialty pharmacies and distributors to correct safety issues or have sort of financial leverage as they otherwise would. And a number of providers spoke about challenges with the drugs that arrive that are not streamlined with their in-house pharmacy systems that they've developed to maintain safety. Okay. And but other providers did talk about a number of safeguards they use, and we'll turn to that. On the access side, white bagging just has inherent challenges that don't exist with buy and bill. If the drug does not make it in time for the patient's appointment, the patient has both experience, frustration, financial implications, expenses for transportation, childcare, lost work, and the safety impact of potentially missed doses, low drug adherence. In some cases, especially with smaller providers, white bagging has actually or can actually improve access. This is sort of not the cases that we heard are less in sort of requirements to use white bagging, but more in cases where smaller providers actually sort of outsource that full apparatus to a given partner to do white bagging and work with them very closely, have care coordination, and find advantages in working with the economies of scale that a larger specialty pharmacy can provide in terms of expertise and resources to negotiate utilization management with insurers. They may have specialized programs for patient to maximize patient adherence. We've heard, for example, Boston Medical Center operates a specialty pharmacy program, essentially white bagging for a number of smaller providers in the area. Okay, so turning to some of those best practices that we heard. Firstly, wanted to reemphasize the site neutral payment policy and some of the advantages there of addressing the safety and access concerns. Again, all of those concerns that I just took through are not applicable in the site neutral payment because it's the same mechanism. There's still the hospital or clinic is still ordering drugs through their same mechanisms, still maintaining the revenue stream, although at lower rates. Other best practices, patient and provider notification is critical, and having a robust exceptions process in cases where the provider does not feel it's appropriate. And that goes for both for white bagging and especially for home infusion clinics in areas. If in cases where it's not with site neutral payment, if we are still talking about using third-party specialty pharmacies, a number of capacities that the third-party specialty pharmacy should have expertise listed here.
Sarah, I'm sorry, I'm obviously on a steep learning curve. What's the definition of specialty pharmacy?
That's a great question, and one that we've spent some time thinking about.
Easily answered.
My understanding, and I do want to I want to sort of extra confirm this with our DPH colleagues, is that specialty pharmacies don't have a particular certification that must be achieved, but the capacity, what distinguishes a specialty pharmacy from a regular retail pharmacy is the capacity to do these types of competencies that are on this slide. This is, the drugs that they are equipped to deal with are that they're equipped to provide storage and handling for drugs that require a certain temperature control at all times, that they can manage risks associated with the drugs. In this case, if we're talking about providing drugs to a hospital pharmacy, it needs to be able to do same-day delivery, so that to minimize the chance of a drug not being available for a patient. Does that?
No.
A lot of questions also come up about which drugs are appropriate here, and we see different payers have applied these policies to all different drugs. But sort of importantly, what sort of basic criteria for whether a drug is appropriate is that it needs to be delivered in a ready to administer, or it needs to be a drug that has a ready to administer dosage form and clinically appropriate dosage. It should not be delivered to the hospital and then the hospital's responsibility to manipulate that drug in any way. And any medication that requires a lab or test patient metrics that could change on that day, say, the dosage would change if patient's weight changed, or different metrics like that would also not be appropriate, because one would not be able to sort of reliably order the right drug in advance. So, what is going on this topic and in other states or at the federal level? We found that few other states have acted on this topic. The exception is Ohio, limiting brown bagging for cancer or cancer-related drugs. On the federal level, there has been quite a bit of discussion on this topic in reports earlier last year from HHS, and then in the fall, HHS requesting comments on a proposal for a Part B payment model, which would significantly change the buy and bill system. This October proposal is more widely known for its provisions on international price benchmark, so that grabbed the headlines. But I was very interested to see the buy and bill provisions there. So I think, sort of given this level of interest from the federal government, it speaks to likely continued attention to this issue. So and finally, based on that analysis in those areas, it brings us to considerations for recommendations. We have summarized our synthesis here. We need to balance considerations for healthcare costs, safety, and access. And I'll just reiterate here the earlier points that we believe that recommendations should reflect the strong clinical consensus regarding brown bagging. For home infusion, recommendations should reflect the potential for safety and access, but also the range of patient preferences. And for white bagging, again, the potential for safety and access concerns, as well as evidence that use of best practices can support appropriate white bagging use. So I'll conclude there and welcome any questions and look forward to discussion.
Thank you, Sarah. I just want to kick it off because I think your last slide is excellent, options and considerations. So the reason why this is going on is basically to save money, because some of the providers charge very high fees for the medications, and they're pretty explicit that that's how they make money. That is, they don't make money off seeing patients, they make money off buying drugs and profiting off that. And so some of them have said to us privately, gee, look, if we take away this source of money, how do you expect us to cover all the other things we do that lose money? To which my answer is, well, that's not should be my worry. But that they're sort of open about that. And then on the other side, there are potential concerns having to do with either safety as it's shipped to the physician or safety in the patient's home or so on. And so these some of them strike me as sort of transition problems, like, you know, we're moving from system A to system B, that just involves some transition costs, and so people have to get used to it, was one. And then some of them strike me as like super duper technical things that I have no way of judging. You know, do you need an exception for this, and how do you deal with a patient who's, you know, wants to do it at home, but their caregiver is not mentally with it and makes that determination, and all of this sort of stuff. And I guess the question is, where do we otherwise in government make these determinations as to like the really, really detailed technical stuff? Because I don't feel like I have any capacity to do that. I'm not sure if legislature has us do that, but I would like have no way to start. Is this like Department of Public Health duties, or who does this?
I would say that an early realization for us is that the level of is that recommendations should focus on principles and safeguards that are broadly applicable, and it would be, I think, outside a reasonable regulatory capacity to say, you know, drug X is appropriate and drug Y is not, or you know, drug X can only be subject to white bagging under X, Y, and Z conditions. So I think that level would be essentially outside the scope.
Does anywhere in state government do that, or do we just say, you know, Geneva legislature, here's what's going on, and you should, you know, stress to the payers that are providing it that they really need to have to insure these, but we're not otherwise going to have a meeting about it.
I mean, there are certainly places where there are regulations put in place on the insurance companies and their behaviors, regulations put in place in terms of the providers and their behaviors.
I don't know where.
Prescription monitoring program would be a good example.
Because I don't know who to give this to and say, okay, look, here's how you legislature should work this out. Other than saying these are considerations, you have to think about them.
I think some of this is there may be some parallels to the discussion on out of network billing, for example, of here's a a broad framework, and this will be applied to providers. Can't do X, must do Y, and this other regulation or law will be applied to insurance. Must do X, can't do Y.
And there are certainly circumstances where there would be a legislative mandate to say the Department of Public Health should promulgate regulations pursuant to these principles, and have that agency then go to the further level of technical detail through a regulatory process as opposed to just in law.
Any other comments from other commissioners? Thank you very much. Dave, I'm going to suggest that since we've used all of our time, that we come back to the issue of RPO in our next meeting.
That sounds great.
Rather than try to rush something here,
Yep.
because I think we should hear all of the issues appropriately.
So the one thing before we close this meeting and start the next meeting is Sarah, if you can just switch all the way to the end, slide 74. Just a note for everyone here, if you're not staying for the next meeting, our next public meeting is March 13th. It's at the State House, and this is our annual public hearing on the potential modification of the healthcare cost growth benchmark. So please note the information. It's on the last slide in your handouts. And if your organization or if you are interested in testifying at this hearing, there's contact information, and we're starting to collect people to sign up for testimony starting today.
Thank you very much. And we will adjourn.
Great.
Thank you.
Thanks, guys.
Thank you, Ron.
All right, we're just going to take 3 minutes to reset the room for the next meeting. Thank you. All right.
takes like 7 minutes.
I didn't know if there was like if you cut it off so that you put them up on YouTube.
I have like, the other meeting has to end early enough.
I was just curious.
Yeah. Are you here? Are you here for the next one too? That's okay. They're very different, so.
I just want to briefly review our agenda today, and we have an update on the two certification programs that HPC runs, the Patient-Centered Medical Home and the Accountable Care Organization. We have a wonderful presentation on neonatal abstinence syndrome investment, the program evaluation that HPC has been involved in over the last couple of years, and then the schedule of our next meeting. I want to welcome Commissioner Blankney to our committee, and we'll start with the approval of the minutes of November 28th. If any corrections, additions, deletions, if not, a motion to accept. All those in favor? Opposed? Abstain? Abstain. Okay. And I think if I read the minutes correctly, we also have to approve the minutes of October 13th. Is that my? Sure. All right. So I need a motion.
These people are saying yes.
I see a lot of shaking heads. A motion to approve those minutes. Any corrections, deletions, changes? If not, motion to accept. All those in favor? Aye. Opposed? Abstain. Barbara was abstaining. Okay, now that we have all those formalities out of the way, we had a listening session in early January on the certification standards for ACOs. There was a lot of public input on that, as well as discussion from our last meeting about patient-centered medical homes. So we have an update on where we are with those two programs. And Katie or Catherine, I don't know who's up.
I'll tee it up just because we have a couple news table, but I know that we haven't formally met a new commissioner, but also a new staff person on my team, Mike Stanek. Mike is the manager of care delivery programs and oversees both our PCMH and ACO certification programs. He comes to us from doing risk contracting at Partners Healthcare. So we're very lucky to have him, and he will be going through the ACO presentation with Catherine, but I will turn it over to Catherine to go over the PCMH update first. Perfect, thanks Katie. So good morning commissioners. I do want to start off with just an update for you on our PCMH Prime certification program, which is for primary care practices and focuses on the integration of behavioral health into primary care. We talked about this program at some length, actually back in June. So I just want to update you a little bit on a discussion from that meeting and talk about where we are today. When we last spoke about this, we were coming up on the expiration of our contract with NCQA, which is a key operational and strategic partner for us on this program. At that time, we also discussed that NCQA had launched a new distinction in behavioral health integration program itself, which incorporated many of the same standards that we had in our PCMH Prime certification program. So in light of that, we recommended to the committee that we phase out our PCMH Prime program standards and instead enter into a new contract with NCQA, under which we would adopt the distinction in BHI program as the new standard for our certification. So we expected under that 2-year arrangement with NCQA to maintain an operational relationship with them that would include receiving data from NCQA on the practices that had achieved distinction, supporting training webinars for practices, and covering the fee that NCQA would otherwise charge practices to apply for that program. So in keeping with that, the HPC did sign a new contract with NCQA last month. And we've announced that, as we expected, the current PCMH Prime program will sunset as of April 30th, 2019, and the new distinction program will qualify practices for HPC PCMH certification going forward. Now, the final terms of our contract with NCQA are a little bit different than what we had originally planned. We did some more thinking internally about the nature of this relationship. We had some discussions with NCQA about it as well. And we really, through that process, came to the conclusion that the resources needed to continue a long-term operational relationship with NCQA were likely to be greater than the overall benefits of this. As you know, commissioners, we had some challenges along the way in the relationship, and so thinking about all these factors together, we signed a shorter term agreement with NCQA just through the end of July 31st, under which they will review all of the applications for PCMH Prime that are submitted by April 30th and share with the HPC the data on those practices for certification. Beyond that point, our intention is not to have a formal contractual or operational relationship with NCQA. This does mean that we do not plan to sponsor training webinars on their distinction program, nor cover the fee that practices will pay to apply for distinction, which we understand that NCQA has set at a flat rate of $500 per practice. So the way our certification program will work is we'll have a simple process for primary care practices that receive the distinction from NCQA to let us know about that. We'll be able to check, verify that information using public data on NCQA's website, and we'll grant certification on that basis. And following on the conversation today, our intention is to update the practices with this information and start letting them know the details of exactly how this will work. We still think there are opportunities for a more strategic relationship with NCQA going forward, and we're looking forward to engaging them in a variety of ways, such as in the areas shown on this slide. Thinking about, as a standard setting organization, certainly we see them as a corollary to what we're doing in some ways with our certification programs. And we think too that there might be strategic opportunities in the areas of quality measurement and addressing administrative complexity, given NCQA's role in the HEDIS measurement process. And of course, I do acknowledge that some of the decisions that we've made about this in the latest contract come with some downsides to our cohort of practices, particularly with regard to this issue of our covering the fee. And I do want to say that we're recouping a significant a number of dollars, about $150,000 probably, through not having this longer term relationship with NCQA. And so we're already thinking internally about what we can do with those resources, put them back out into the domain of the practices, and continue to push forward with this interest that we still have, of course, on the integration of behavioral health into primary care. So just a few early ideas reflected on this slide about projects that we might undertake in this area. We're early days in that thinking, but I do want to highlight that our intention is to return these dollars to practices just through another way. So that is my update, and I'd be happy to take any questions or reactions.
Do we know how many applications are in the pipeline currently?
And NCQA? Yeah, there are somewhere in the neighborhood of 5 to 10. And I expect that number will probably increase as we take closer and closer to April 30th.
And the prime certification, even for practices now, that is for 2 years, correct? So there will be prime certified practices in the future.
That's right.
And then on a rolling basis, to continue to be certified, they would need to seek NCQA's behavioral health distinction.
That's exactly right.
Any other questions?
Okay, so now on to our ACO certification program. And I'm going to try fairly quickly to do some context setting. And then Mike is going to take us really into the meat of the presentation today, which is to describe the analysis of public comments that we've done, which he led along with our colleague Courtney Anderson, and then on to our final recommendations to you for the 2019 certification standards. So it's our hope that with your endorsement today, we'll go forward from here and fully build out the certification application and open the submission process this fall. So this is an exciting milestone for us today, reflecting a lot of work over the past several months in particular, but really taking us back to 2017. This is only the second time that we've been in the process of setting standards. Our first time out was just really over the course of the year in 2016, and then opening up the program for the first time for certification in 2017. So today we're really trying to build off what we have learned from the first round of certification and on the information that we were able to release in the course of 2018 through a series of publications. So just some reminders about kind of key milestones leading us up to today. I I do also want to take a moment to remind us that ACO certification exists within a context, and part of that context is that there are a variety of ACO models in the marketplace designed to meet the needs of different patient populations. So there are Medicare ACOs, there are commercial ACOs. Mass Health has launched a robust ACO program, and while some of these models are now 5 or 10 years old, the evidence on what makes for a successful ACO really is still developing, and we're cognizant of that as we approach this, these goals that we have around setting a set of standards for certifying. So those goals include that our program is designed to create a multi-payer approach, a set of standards that apply to any patient population that the ACO may be serving. Another really important goal for the program is to build public knowledge and information about and transparency about ACOs. We see that as really a core feature of what we're trying to do. And through that process, really helping facilitate learning across the healthcare delivery system. And of course, always as well, supporting the care delivery standards and priorities that are set by other state agencies. And I would say those were our goals in 2017, and they remain our goals today. Now, the future vision for certification is that really, as the evidence base continues to develop, that we'll be able to move our certification standards from the more structural process requirements that we've had in 2017 and that we're proposing to continue for now anyway, and toward really looking at ACOs based on quality outcomes and cost performance. So that's really where we're headed in the future, and this is really consistent with what's anticipated in the statute around that charges HPC with establishing the certification program. There is this notion in the statute of a model ACO that could be used for preferential contracting terms in the future, and that would focus on really understanding what are the best practices and what is a model ACO. So this is just a quick reminder of our 2017 ACO certification standards. I won't talk through this in detail, but I'll just highlight the 3 categories of things. We had a set of prerequisites that really spoke to state and federal legal obligations and requirements. We had a category that we call assessment criteria. There were 6 criteria in this category. We set a particular standard around these topics and assessed or evaluated ACO's demonstration of whether or not they met that standard. And then the last bucket here required supplemental information. This was a category where we wanted to put these topics on the table as important capabilities for ACOs, but not yet ready for a standard to be set. So we posed particular questions in these areas, required complete responses from ACOs to all of these questions, but did not evaluate the answers. Under that program in 2017, to date, we've certified 18 ACOs, and this includes the 17 that are contracted with Mass Health, and 1 additional ACO that sought certification outside that context. And I'll just reiterate here, it's worth stating that when we ask for applications from ACOs and when we evaluate them, our lens is at a multi-payer level. So while they might be participating in the Mass Health ACO program, when they come to us for certification, we're looking across all of their risk contracts. That might include also Medicare commercial. And just so for our new commissioner's sake, Mass Health does require ACOs to be certified by us, but on that all-payer lens, not just for the work that they're doing for Mass Health. So most of these organizations structurally set up a separate legal entity for their Medicaid ACO, Medicare ACO, and commercial, but we're looking to help them. But Mass Health does have that contractual requirement. Okay, so before Mike takes over, just one more point that I want to make, which is that the information that's submitted to the HPC for certification really is finding its way back out into markets, where we hope that it is helping further that goal that we have of providing greater information to the public in general and to interested stakeholders in the healthcare community who may learn from what other ACOs are doing. So in 2018, leveraging data from ACO certification and other public sources like the Massachusetts Registration of Provider Organizations program, we issued 3 publications, including 2 policy briefs and a packet of what we call profiles of ACOs, 1-page descriptions of these organizations. We have, I'll just mention, a 3rd policy brief in the works that we're hoping to release very soon. focused on risk contract and performance management approaches of Massachusetts ACOs, leveraging again much of the information that we collected in certification last year. And in addition to those written publications, we also recently really had a great a webinar event leveraging information from our 2017 supplemental information question on ACO approaches to serious illness care. This was a collaboration with the Massachusetts Coalition for Serious Illness Care and featured just some fantastic speakers from several of our certified ACOs. Attendance was great. I think the panelists really added a lot of flavor and color to the information that we got in certification. So we saw this as a great first stab at kind of using certification data as a platform for this kind of convening with ACOs, and I think we're really interested in doing more of this kind of two-way information sharing type of L&D work, learning and dissemination work in the future, including in 2019, 2020. So I think that's all the context I wanted to provide. Katie, is there anything I've missed or?
No, and Mike will get into this. I want to take a moment to say thank you to all the stakeholders who submitted comment to us, and all the stakeholders who met with us over the past 6 months. We've really taken a really hard look at the value that this program provides to the market from a transparency perspective, from a standard setting perspective, and feel that we've come up with a good proposal here, but really interested in commissioners' feedback and thoughts. Particularly as we undertake the first recommendation in the cost trends report about addressing administrative complexity. The last thing we want to be is adding to administrative complexity that does not have value, and that's an important qualifier there. So took a hard look at the value that this program provides to the market. We heard from health plans, we heard from consumers, we heard from a lot of providers, thank you. And so I just wanted to say that note of gratitude, but we're really interested in your feedback on this proposal and look forward to moving forward. So we'll let Mike take you through the proposal.
Great.
Thanks, Kate. Hi, everybody. Late last year, after engaging a range of stakeholders, we released our proposed 2019 ACO certification requirements for public comment. In them, we proposed to collect, in the background information section of the application, the same prerequisite attestations as in 2017. Additionally, we proposed to collect a brief narrative describing the applying entity and information on the regions of Massachusetts in which the ACO delivers care. We further proposed to collect, as background information, some data that in 2017 were assessment criteria, including features of risk contracts and performance on quality metrics under risk agreements. This risk contract information and performance data would be collected using standardized templates provided by the HBC. We proposed that the assessment criteria remain unchanged from 2017. ACOs seeking recertification would be given the option to attest to their 2017 submissions or would update information that is no longer correct. We asked for comments on supplemental questions in 9 topic areas, selected for their potential to either add to the evidence base around practices and strategies used by ACOs, or shed light on emerging areas of focus in understanding ACO approaches to providing integrated, patient-centered care. Finally, we sought comment on a proposed voluntary distinction program that would recognize ACOs that have achieved improvements in the domains of the triple aim and in health equity, as well as committing to specific strategies to continue improving. So we received 18 public comments in our proposal, including 10 responses from certified ACOs, 7 from public health or advocacy organizations and coalitions, and 1 from a government agency. These comments included feedback on both the ACO certification standards and the distinction program. So I'll cover comments on the standards first, then I will walk through the feedback we received on the distinction program. Commenters consistently urged us to be thoughtful about opportunities to simplify or streamline reporting requirements associated with certification requirements. There was interest in exploring greater consolidation of ACO reporting across state programs, particularly as it relates to risk agreements. Some respondents suggested that we consider additional criteria for certification in the future. We do anticipate that the program's assessment criteria will evolve over time, particularly as the evidence base for and experience with ACOs grows. Finally, there was interest in continuing collaboration between the HBC and certified ACOs, both with respect to the upcoming application process and with respect to using data and meetings to provide learning opportunities for ACOs. With respect to the proposed distinction program, we entered the public comment process understanding that there are widespread interest among commenters in the HPC taking a very deliberative approach, taking the time to undertake a more extended stakeholder engagement process to design the program parameters. In that vein, commenters expressed interest in better understanding the purpose and potential benefits of participating in the distinction program. We heard clearly that stakeholders are interested in working through some of the challenges associated with evaluating performance across payer populations and risk contracts. In addition, the commenters stressed the importance of aligning the distinction program with existing approaches to performance measurement.
I mean, I think the good news is we also heard support for health equity, but I think a general agreement that it's going to be hard to decide how to measure that. But I think we were pleased to see that support for that proposal that we put out.
So the feedback we received about streamlining the application process where possible resonated with us. In the HPC's recently released 2018 cost trends report, we identified administrative complexity in the healthcare system as a major focus area of the Commission for the coming year. And so this weighed heavily in our thinking in determining our recommended final ACO certification program criteria. We are committed to considering the HPC's role in the administrative complexity of the system. However, we must balance this with our charge to set meaningful standards for care delivery for ACOs and to fulfill our goal of providing transparency on ongoing developments in risk contracting and care redesign among ACOs in the Commonwealth. Several public comments questioned whether there are opportunities for the HPC to use data collected by other state agencies or other programs. We investigated existing reporting requirements for health systems, including to the Department of Insurance, the HPC's Registered Provider Organization program, and for the ACO certification program. And we found that at present the overlap is limited. The primary points of difference between data elements collected for ACO certification and other programs is that data for ACO certification is collected at the contract level and is largely held confidential. In order for us to understand developments in the market and to explore the relationship between risk incentives and care delivery redesign, the unique risk contract level data we collect and our ability to hold such data confidential are critical. Because of our review of these data reporting requirements, we do feel confident that our data request is distinct from what providers are currently reporting for other programs. But as we will discuss later in this presentation, we will pursue opportunities to achieve greater alignment among these various reporting requirements in the future.
I think the only, it doesn't relate to risk contracting, so it's not on this slide, but the last program that sort of is usually spoken to in the comments is the RBPO Appeals, ACO Appeals program. It's sort of the Division of Insurance's RBPO, which is downside risk ACOs, our certification program, our RPO program, and our ACO Appeals are sort of generally cited as ACO reporting programs together. But we didn't include that one here because ACO Appeals is patient appeals. It doesn't have to do with what kind of risk contracts you had. But we really ran down this. Is this the same information that the Division of Insurance collects? Because most ACOs suggested that to us. And in our analysis, it's not, largely due to the aggregate versus specific contract nature of the information that we're seeking. And obviously, big difference of confidentiality of the data versus both RBPO and RPO, which are public aggregate programs. Lauren, you had a question?
Did you look at to what extent this information is reported to Mass Health and where there's overlap there?
We did. I think the nature of the reporting to Mass Health is based on the contractual basis that they have as a payer. But as you'll see later, we really are open to exploring with Mass Health, Division of Insurance, across programs within the agency about how we can align that reporting.
Thanks, Katie. So keeping in mind both the public feedback we received and the results of our research showing the continuing need for us to collect information at that contract level, we try to be thoughtful about proposed data elements that could be removed from the ACO application without jeopardizing the goals of the program. As a result, we made a number of changes to our proposal. On the background information, we're now proposing to slim down some of the demographic information we will see from ACOs. We're proposing to pull from existing registered provider organization data to understand ACO participants, preserving the right to follow up with ACOs for additional clarifications when necessary. And we will eliminate the requirement for ACOs to report member management fees or infrastructure payments under risk contracts. Finally, while ACOs will still be required to submit performance data on quality metrics used in their risk contracts, we will not require ACOs to submit this data using a standardized template.
I just want to make a manager set as opposed to having them map it to the aligned manager set and then send it to us. That's the only difference there.
All other background information elements would still apply. Generally, there was support for our proposal around the assessment criteria. As such, we propose to proceed with the assessment criteria approach outlined in our request for public comment document. We will retain the assessment criteria used in the 2017 application. We believe these criteria balance our goal of identifying meaningful structural and care delivery standards for ACOs with the need to provide a degree of consistency and administrative relief to participating ACOs while the evidence base for ACOs continues to grow. As proposed, information collected around quality-based risk contracts will be moved to the background information portion of the application. To help streamline the application process, ACOs applying to renew their certifications will be required to review their 2017 applications and may attest that the 2017 response is still fully accurate and applicable. Though we did not make updates to the assessment criteria, we are seeking to gather new data on ACO activities through the supplemental questions in the application. We view these questions as an important mechanism for promoting transparency, for highlighting areas that we expect ACOs will focus on. So we asked for public comment on supplemental question topics in the following two domains. The first was adding to the evidence base, and the second was emerging topics of policy interest. The particular topics that we considered were distribution of shared savings and provider compensation, providing high-value care, behavioral health integration into primary care, advanced HIT-enabled care coordination, coding, market functioning, workforce, integrated innovative care models, and community partnerships to address social determinants of health. Based on public comment feedback and reflection on the various mechanisms by which information is collected from providers across state government, we landed on three particular topics for supplemental questions: the distribution of shared savings and performance-based compensation, high-value care, and advanced primary care and behavioral health integration. Collecting information on the distribution of shared savings and performance-based compensation is critical to understanding how ACO-level incentives and risk contracts are translated into clinician-level care redesign, and to building the evidence base for practices used by successful ACOs. Excuse me. Efforts to promote high-value care and reduce low-value care remain a priority for the Commission. We seek to understand ACO strategies in addressing known cost drivers that have impacted performance against the cost growth benchmark, such as unnecessary utilization of low-value care, prescription drug use, and post-acute transitions. Finally, supporting advanced primary care and behavioral health integration remains at the core of the ACO model, and we anticipate there's much to learn from ACO approaches in this area. So in developing the supplemental questions, we are committed to balancing the need to recognize that ACOs may be employing a wide variety of approaches and strategies, with our intent to collect data in a format structured enough to allow research and dissemination. As we did in the first cycle of ACO certifications, we plan to use data obtained through the supplemental questions to provide learning opportunities among certified ACOs. So I'll turn it back to Catherine to dig a little bit more deeply into the supplemental questions and my thoughts on them.
Initial questions here. Okay. So the next, I think, just 3 slides, commissioners, we've tried to draft out some of the supplemental questions that we'll ask in each of these categories. Our intention here is not to review these in great detail with you. These remain draft questions at this point, but to give you a little bit better flavor for what we mean when we say we're going to ask questions on a given topic. We thought it might be helpful to show you some of our early thoughts about what these questions might look like. Our process will be to work much more diligently internally and come up with the final set of questions over the next few months as we develop the application. So
one other just quick point on developing the questions. There were a couple of suggestions made to us to collaborate with the research community, the ACO research community. A lot of them happen to be very local, about how to best craft these questions. So this is a proposal, but we do look forward to working with folks in the community to craft these in the best way possible.
So on distribution of shared savings and provider compensation, our intention here is really to build off a similar set of questions that we asked last year, where we provided a fairly open-ended opportunity for ACOs to describe to us how they think about distribution of shared savings or allocation or responsibility for losses in that kind of case, and what their provider compensation approaches are, what kinds of factors weigh in. Because of that open-ended nature of the question, there was a high degree of variability in the level of detail provided in their responses. And to enable a little bit more rigorous analysis this year, our intention is to go with a somewhat more structured set of questions such as those you see here. So asking ACOs to sort of do a multiple choice for us on a variety of things here, including how they incorporate risk-based incentives into their compensation model, kinds of factors that they consider when they're developing a shared savings or surplus or deficit distribution methodology, etc. In terms of high value care, as Mike was just saying, this remains an area of focus for the HPC, and we'd like to pick up on that theme. This would be a new topic area in ACO certification. So again, here we're proposing to ask ACOs about if they have strategies around reducing areas that have been identified as low value care, including those that we name in our cost trends report, but others also. Particularly, we'll also ask a question around the cost-effective utilization of prescription drugs, which we know is a hot topic, and around post-acute care as well. And finally, as the evidence does seem to be growing that a strong foundation of primary care and access to integrated behavioral health services is so important in the ACO context, we'd like to again gather data and certification on the ACO's strategies in those areas. So we're proposing to sort of broadly pose a strategy question and get some information about the ACO's overall approach or their health system's approach to supporting primary care. We're thinking about, with some helpful suggestion about this in public comment, leveraging the SAMHSA ARC levels of integration scheme as a way to collect some standardized information on the level of behavioral health integration at primary care practices that participate in ACOs. We're interested in reverse integration models for cases where that's a better approach for patients. And particularly in light of MassHealth's recent announcement on their new policy on telebehavioral health, we're thinking about asking about current or future plans that the ACO might have to offer behavioral health services via telemedicine. I'll touch just a little bit on confidentiality, and then again I'll pause for questions if there are any or reactions, commissioners. But a word about confidentiality. So the data that are submitted to the HPC for ACO certification, unlike most other data that is submitted to the state, is protected from disclosure under law. So much as we did last year, our intention will be that we will not report attributable information in the public domain in most areas unless the ACO consents. So if the ACO tells us in their application that they give us consent to disclose particular aspects of their responses, then we can do that. But otherwise, we've identified just a small list of elements from the application that we propose to potentially use in public reporting, even without ACO specific consent. This is really in line with our approach from last year. And so those elements for public reporting are really limited to just basic contact information about the ACO, the names of the payers with whom they have risk contracts. This year we'd also like the flexibility to report on information around the year that the contract began and it expires, and whether it's an upside only or a downside risk contract, along with the number of attributed patients. And then just as we did last year, there are a few elements from our assessment criterion on the ACO's approach to providing a patient-centered approach in their governance, such as the location of their patient or consumer advocate within the governance structure, and a description of how they operate a patient and family advisory committee. All right, so this just is a little bit of a crosswalk. We've had some evolution. There's been quite a progression of this program, as you know. We came to you earlier in the fall with a particular set of proposed standards. The version that we put out for public comment was a little different, and our final version today is different in some significant ways. Again, I think this reflects really how important the stakeholder engagement process is to us, and how seriously we've taken that feedback and thought really hard, to Katie's earlier point, about the role of certification in collecting information. I will say also that that kind of thinking has led us to think about other opportunities that the HPC has at our disposal to collect information from the health system, such as through pre-filed testimony. So there may be cases where rather than have a supplemental question in the ACO certification application, we might pick up on that theme in one of those, one of these other formats. So, our ongoing commitment to learning about ACOs, both through the certification program and generally, remains strong. I also just want to mention, I'm just so, I would do that.
Comments, questions? I think you've shown great restraint here, and you really balance the need for us to dig deeper in the information and know more about ACOs with the burden that places on the organizations themselves, and also the fact that this is a new process. We're just about a year into it, so I give the staff tremendous credit for balancing all those objectives, and it's something that I think is much better than where we started when we started this conversation a couple of months ago. It's just my own observation. Thank you, Commissioner. And I would just add, I think part of the reflection that we got from some of these comments was just that these things are still evolving and take some time. And so, was this the appropriate time for us to completely rehaul our certification standards, or was there an opportunity here for us to build off what we did in the first standards, have some small updates, but really not this cycle kind of rehaul everything and create a whole bunch of new standards. I think we retain that option in the future to evolve this program, and one of the things that is still on our list of things to do is to spend our energy and resources that may have otherwise gone into kind of create a whole bunch of new standards and new information, but shift some of those energy and resources to one, developing this distinction program and spending some more time to think about what a performance-based, outcome-based distinction program may look like. I think we heard a lot of interest in that idea, but also that it will take some time to really kind of think and put that together. And secondly, to do a little bit more of the convening and the learning and the dissemination with some of the information that we have. And so rather than collecting a bunch of information that retains in a black box behind this confidentiality, let's be a little bit more focused on what we want to focus on, but then, again, use some of our time and resources to engage in that ACO community, like with the webinar. So there's trade-offs in all of these different things, and it's trade-offs for the HPC, it's trade-offs for the provider organizations, but I think we try to strike a balance.
This might be stating the obvious. I know that you've been working with the Mass Health ACO team on some of these issues, but I think it's important to keep in mind where we're asking supplemental questions to understand and measure the success, for example, integration of behavioral health and primary care, that the answers that you're anticipating to receive and the way that you're going to evaluate whether the level of integration should be consistent with how Mass Health is measuring that integration, so that we're not developing different metrics and standards for how we succeed in each of these domains.
Absolutely, it's a really important way to focus on. Okay, just a couple more points. So, the other thing we're really committed to over the course of the next several months, much as we were and did in 2017, is making the application process as easy as possible for ACOs. So this year we are building a new application system, which I really hope comes through with some improvements over the process last year. I will say ACOs will not have to download any software this time around. This will be a web-based platform, which itself is an improvement. We anticipate ACOs will have the ability to access their 2017 responses and their data, so that should make the attestation or updating process for the assessment criteria easier. And we're working on improved functionality in general. So watch this space, but we have hopes that the process will be a little less painful this time. We plan to issue the full application requirements this spring, which should give plenty of time for ACOs to understand what they are before the system is open and live for them to actually start writing up their applications. And much as we did last year, we will be ready and available and proactive in reaching out and offering training opportunities, in providing technical support on a one-on-one basis throughout the process. Last year we had office hours, we put out written FAQs, we did training videos that we posted, and all of those things are on the table again this year. And this whole team is really committed to making it smooth as much as we can. I think this point has been well made, but I will just reiterate here that as we really think hard about this issue of administrative complexity, we're thinking hard and we're making an internal commitment that over the next year or so, we will work with our own internal staff to try to continue to identify opportunities for administrative simplification across the various ways that the HPC collects information and develop plans for implementation. We hope and look forward also to engaging our state agency partners in that work. A quick note about timeline. So from our conversation today, we will move forward in developing that full document that we call the PUG, the Application Requirements and Platform User Guide. We anticipate opening the system for applications in August or September, with applications due tentatively in October and decisions by the end of December. I'll put a bit of a sort of asterisk on all of this timeline, and I'll just say that hopefully our development process goes smoothly. Should it not, or should there be other factors this fall that would make it difficult for ACOs to meet this particular timeline, I think we're open to exploring an extension of the current certification for a little bit of time in order to make sure that both our system is working smoothly and that ACOs have adequate time to respond to the application. So please stay tuned for more on this. We're flexible. And finally, just to circle back on the ACO distinction program, as we've said, we have a lot of feedback and public comment that this is an interesting idea, an interesting concept, and a suggestion that rather than commit to a 2020 launch of this program, we might be better served to really think about it thoroughly and thoughtfully first. So that's exactly what we plan to do through a robust stakeholder engagement process after we continue to kind of formulate our thinking internally. And we'll let that process drive a timeline for implementation as opposed to trying to set one in priority.
Any other points on the certification programs? If not, we'll move to our presentation on neonatal abstinence syndrome, the evaluation results, and
So we will have Griffin Jones, our Senior Program Manager of the HCII program, and Dr. Manish Gupta, who Griffin will further introduce, will take us through this part of the presentation.
Great. Good morning, Commissioners. And thank you very much for this opportunity. It is my distinct pleasure to introduce the interim results from the first year of our neonatal abstinence syndrome interventions, and that is truly to introduce our partners in this work and really the driver behind the inpatient QI portion of these initiatives, our partners, the Neonatal Quality Improvement Collaborative of Massachusetts, chaired by Dr. Manish Gupta, and we also have his colleague Mary Hogan in the audience too, who's integral to these initiatives as well. So my job here is to give as brief a context as possible and get right to the important points for a substantive discussion. So as a brief reminder, the neonatal mother and infant focused neonatal abstinence syndrome interventions, which I will henceforth refer to as the NAS interventions for time, it sits underneath our Healthcare Innovation Investment Program, whose charge was to deploy innovative, cost-saving and quality-improving practices and modalities at some of the Commonwealth's most persistent challenges, and especially for those the Commonwealth's most vulnerable populations. And I think there is no more exemplary piece of this program than the NAS interventions, who serves pregnant women with opioid use disorder and substance exposed and their substance exposed newborns. So diving into that, recall in 2016, we engaged in a competitive a procurement process to seek out birthing hospitals who could deploy innovative protocols and supports for substance exposed newborns and their mothers. The initiatives currently and have spanned across the Commonwealth, all the way out from Bay State Medical Center in Springfield to a bunch along the Northeast corridor and out to Beverly and Lawrence. Ultimately, $3 million worth of funding has been deployed to these hospitals in order to do this work over the course of a 2-year implementation period that we are still engaged in for 3 of the remaining hospitals. All told, these are not just the birthing hospitals themselves, but represent communities of practice that have really developed through the support of the learning collaborative that you're about to hear about, and the work of these amazing organizations and teams within the hospitals who have done this work. Briefly, there are 2 basic varieties of our NAS interventions. All 6 of our interventions and awards have applied and gone through the inpatient quality improvement practices that Dr. Gupta is going to walk us through the results of. We have also funded 2 initiatives that have expanded and replicated on the MOPS 2 Care program that was initially funded through a SAMHSA grant through the Department of Public Health, and we are pleased to continue to engage with them as deep partners for those 2 sites. However, today we're going to be talking about the activities and results specifically from this inpatient work, as with the guidance of NeoQuick, and then the larger statewide collaborative that is part of this, the Perinatal Neonatal Quality Improvement Network of Massachusetts, affectionately known as PAQUIP. So recall, here are the 6 awardees. With Leahy Beverly Hospital and Lowell General Hospital are the sites of replication for the 2 MOPS 2 Care initiatives. This slide, I think we need twice as much time to really describe what NeoQuick does for these for the hospitals and our awardees. But briefly, it runs the gamut from kind of direct training and coaching, especially for very specific practices about identifying and treating neonatal abstinence syndrome, but also more broadly into quality improvement training and coaching that they still provide. Learning collaboratives, both for the communities of practice for the identification of neonatal abstinence syndrome, and also for just the larger statewide learning collaborative that they support from PINQUIN. There is a picture of Secretary Sutters, who was the keynote at our fall summit, and I think, not going too far, diminished by encouraging our commissioners to it's an amazing event, these semi-annual leadership summits for the substance exposed newborn learning collaborative, and I invite you all to come. And then finally, measurement and analysis, which is really what we're here to look at today, both in the analysis of the key performance indicators that our hospitals submit to us through NeoQuick, but also in surveying practice patterns and general states of culture and practice overall. Finally, as just a quick tee up to orient you to what the measures you're about to see and generally what the logic model is behind these interventions, there are kind of 4 basic kind of areas of influence that NeoQuick has tried to support our hospitals in affecting. And while we are just talking today about the inpatient care portion of these awards, I think if you look on either side of our sequence here, and you can see that maternal and pre-discharge activities are really important and within the scope of trying to support safe mothers, a safe pregnancy, and then safe postpartum discharge for the moms with their babies. Of breastfeeding during the hospitalization, skin-to-skin care, and then bringing in mother and baby prior to discharge. So with that, I will turn it over to Dr. Luca to walk you through.
Perfect. Hey, thanks so much, Griffin. Yeah, Mary and I are both very excited to be here to share some of the results of this work with you guys. Well, I'll jump right into the data pretty quick. I just want to say two quick thank yous before we get started. First, to thank the commissioners and Health Policy Commission. There's been lots of communities and folks in the state working on improving the care of mothers and babies impacted by prenatal opioid use for many, many years. And lots of folks in the state have contributed careers to this. When Health Policy Commission jumped into the space a few years ago, it moved the field forward, and hopefully we'll see some of that data today. I think the commitment of your group to helping this population has made a big difference. And the second is we're going to share the data, share the progress, and we're going to share some results that we think are fairly exciting. The hard work in all this was done by these 6 hospitals, and each hospital has teams of folk working on this that are the greatest teams ever. A lot of these hospitals have mothers with lived experience with RBC. I think all these hospitals do. And if you go to these hospitals, see the work they're doing, I know a lot of folks here have been to these hospitals for site visits. It is quite inspiring to see the commitment of these folks who are at the bedside and on the street. So this is kind of our preliminary findings for the first year and a half of this effort. As Griffin mentioned, there is some continuation of this work that we hope to be able to continue to support and to show you even more impressive results at a later date. A few notes on the data you'll be seeing. Most of my presentation will be data slides. The data is from the 6 hospitals that Griffin mentioned. The data, with the Health Policy Commission, we set up a data form of core measures. We set up a REDCap database to facilitate data submission, data collection, and we set up systems to do data analysis. Every hospital received quarterly progress reports. We also did monthly statewide progress reports. I do want to mention, while we're focusing on the 6 hospitals that were part of this initiative from HPC, our broader collaborative is open to all hospitals in the state, and this database currently contains data from over 25 hospitals. And that's important because from the initiation, from the start of this project, we were focused not only on supporting the 6 hospitals, but in HPC's direction on also thinking about spread. And this database with shared data among 25 hospitals is a core part of kind of the spread, is the same piece of this work. Our denominator for this database is infants at risk for NAS. We're not going to get into kind of the medical definitions, diagnoses, and care too much here, but neonatal abstinence syndrome is the actual withdrawal syndrome that babies may experience after being exposed to opioids in utero. Our denominator is not babies with NAS, but babies at risk for NAS due to utero opioid exposure. The graphs I'll be showing you will look at the measures from 2016 to 2018. As you know, the HPC Innovation Grant Program was launched in early 2017, and the 6 hospitals launched at different times in the first quarter of 2017. I'll be showing you what are called 1 charts. Those are a type of statistical process control charts that use statistically rigorous methods to look at changes in data over time. And then all told, the data reflects over 1,200 mother-infant pairs, which is quite a big population. Some abbreviations which are in the handout, which I won't go through, that you'll be seeing over the next slides. We divided our data presentation to 2 major sections. In part 1, we'll go over kind of our 4 key measures, that data that Griffin showed on one of the earlier slides. These graphs will be for all 6 hospitals together. In part 2, we show you some subgroup analyses that we think highlight important additional results, as well as we highlight some hospital-specific examples of data that we also think are good lessons. So part 1, so key measures, all HPC hospitals. These are the measures I'll show you. As Griffin mentioned, we divided these into kind of 4 epics: maternal, neonatal, non-farm, and pre-discharge. The neonatal and non-farm care are the main focus of our work. That's kind of really the inpatient piece. We'll show you the results first. We'll show each of the graphs, but this is kind of the summary of part 1. So we'll see that there's a relatively high rate of medication-assisted therapy, MAT use, among mothers of opioid-exposed newborns. So that's a good thing. So one of our main goals as a state is to identify mothers with opioid use disorder, get them into treatment, and a core part of treatment is MAT as early as possible. So we want as many of these mothers to be on MAT at the time of birth as possible. We saw a relatively high rate, but we could be higher. We saw substantial reductions in numerous key outcomes, which are good things. The need for farm care, need for ICU care, and length of stay. These are real important improvements, and you'll see more details on these. That being said, there's still always room for more improvement in both our non-farm care measures and our pre-discharge measures. I'm going to take you through the structure of this slide just for a minute. All the other slides will have a similar structure. So this is one of our measures. This is the percent of mothers of opioid-exposed newborns who are on MAT, medication-assisted therapy, during pregnancy. Yeah, this is what's called a run chart. The blue line reflects the overall performance of the HBC hospitals from 2016 through 2018. The dashed line is the median. The median is what allows us to use these statistical rules to look for changes in performance. Some of these graphs you'll see a shift in that median, and that means there was a statistically important change in that measure. The 2016, we're calling our baseline, 2017, 2018 reflects the work of the HBC NAS innovation program. So for this measure, you can see that we did not see a change in the measure over time, but we did see that approximately 75% of opioid-exposed newborns were born to mothers on MAT, which is a higher number than we expected. Of those, however, 25% about were also exposed to illicit opioids during pregnancy. So there's still room to go on identifying these mothers earlier and getting them access to treatment.
Quickly just speak to the sort of epidemiology of the opioid epidemic in Massachusetts at this time, sort of where the rates of opioid, I'm not going to say mortality, but opioid use disorder increasing, decreasing, so that is context for these charts.
Sure. Yeah, I think overall, it's not a secret that the opioid use has been increasing quite dramatically for the past 10, 20 years, and that includes all populations, including women, including childbearing age, including pregnant women. There are some hints in the last year or two that there might be some kind of measures of opioid use that are flattening. So far, in the perinatal space, we have not seen that the incidence of perinatal opioid use and unilateral syndrome has been increasing in Massachusetts. Compared to other parts of the country, you may know that New England is particularly hard hit by the opioid epidemic, so our rates of perinatal opioid use and NAS are higher in Massachusetts than in most states. Does that answer your question? Yeah, so this is now we'll get into the neonatal measures. This is the percent of term opioid-exposed newborns who required pharmacologic therapy for NAS. I'll just make a quick mention. Historically, the mainstay of treatment for neonatal abstinence syndrome or neonatal withdrawal from in utero opioids was pharmacologic therapy, so giving the babies opioids to treat the withdrawal, much like we would do for adults withdrawal. More and more, we're finding that if we focus on non-pharmacologic care, which Griffin mentioned, keeping the family together, using breast milk, providing skin-to-skin care, providing a good nurturing environment, we need less pharmacologic therapy. And for numerous reasons, which we don't have to get into, needing less pharmacotherapy for the babies is a good thing. So here we see one of the results that we're very excited by. With the HBC Innovation Program, the need for pharmacologic therapy among the HBC hospitals, among term opioid-exposed newborns, decreased by a third. So 66% of these babies needed pharmacotherapy in 2016, now the number is around 44%. This is the median duration of pharmacotherapy. So among those babies who did need pharmacotherapy, are we doing a better job of needing less of it? Can we lessen the duration of it? So far, we have not seen a decrease in the duration of pharmacotherapy. So most of the interventions appear to be most effective at avoiding pharmacotherapy. There's reasons why we think this measure is going to move as hospitals have moved beyond their first interventions to even more kind of innovations. And there's several things that hospitals have started to implement that we think will move this measure. This is the percent of these babies that receive care in an intensive care setting, either a special care nursery or a neonatal intensive care unit. Historically, many hospitals as standard policy put these babies into an intensive care setting once they needed pharmacotherapy. More and more we're seeing that that may not be necessary. And if we can keep these babies in a non-intensive setting, which mainly means being able to keep them with their families, with their mothers, you can still care for them appropriately. So a big effort across the state is to move the care of these babies from intensive care settings to non-intensive care settings, mainly to provide family-centered care. There's also obvious benefits around cost. And we've seen a decrease in this by about a quarter. So overall, the percent of babies being cared for in intensive care setting decreased from 56% to around 43%. This is the median length of stay in the intensive care unit. So among those babies who did get cared for in NICU or SCN, was length of stay in that intensive care setting. This is also decreased from 21 days to around 18 and a half days. This is overall hospital length of stay. In addition to those earlier measures around farm therapy and the need for intensive care, this is probably the other major improvement we're seeing that we're most excited by. So this is the overall length of stay for all of these open exposed newborns. It's decreased by a half, from 17 days to 8 days. The next few slides are about some measures around non-pharmacologic care. Non-pharm care is hard to measure, and so we did our best, and these measures are okay, but we're probably not capturing quite a few elements of non-pharm care. This is the use of mother's milk. This has stayed flat. Around 50% of those newborns receive their mother's milk. There's numerous reasons why some of these babies should not get their mother's milk, but probably this number, we think there is some room for improvement still. This is the percent of babies who get skin-to-skin contact with their mothers in the first day of life. This has increased from 69% to 77%. 77% is fairly high. That there's really not that many reasons why this shouldn't be happening, so we do hope to see this number go up even higher. This is rooming in, so this is the percent of these babies that are able to room in for the mother for at least one night. This number has also been flat, around 70%. There are some reasons why babies would not be able to room in, but not many. We would hope that this number would go up as well. Yeah, this is our one measure around, well, we have a couple measures around discharge, but this is our core measure. So the percent of these babies that are referred to early intervention prior to hospital discharge. You may know that in Massachusetts, any infant with a diagnosis of NAS is automatically eligible for early intervention up to a year of age. EI is also welcoming all referrals of open exposed newborns, not just those with a diagnosis of NAS. This number is around 73%. It hasn't moved, surprisingly. This should be a number that gets closer to 90-95%. Looking into this more closely, we have found some structural reasons why in some hospitals this doesn't happen as reliably as we think it could. So we expected this number to move already. We're a little disappointed that it hasn't, but this is a focus moving forward. Yes?
I'm not sure my question is going to be phrased elegantly, but in thinking about what's happening with the babies, what's happening with the moms in terms of their addiction. I'm thinking, for example, skin-to-skin contact. It depends, at least in part, on the mother's calmness and the mother's ability to relate with the baby, and how does the mother's addiction impact on that. Also, with regards to breast milk and thinking about that. So could you take a moment just to bring us back and talk a little bit about the moms?
Definitely. Yeah, it's a great question, and we'll acknowledge that most of our measures are baby focused, not maternal focused. Partly because these are hospital-based measures for those couple of days right after birth. We are working hard to think about measures that we can get before, during pregnancy, ideally even pre-pregnancy, to really get a better understanding of how these moms are, how effective we are getting them treatment. That being said, during that birth hospitalization, the majority of these moms are actually in a reasonably good spot in terms of the types of topics you're talking about. As we saw, most are on MAT. So if there is some illicit use, most of these moms have at least gotten into treatment. If they're only on MAT, these moms are generally quite good. They're healthy, they're in recovery, they're in treatment. They're basically healthy moms on an opioid. So for those 50-60% that are only on MAT, those moms should be moving in, they should be breastfeeding, they should be doing skin to skin. That there's really little to say that care of that infant should be any different than other infants. For those moms who are trying to get into MAT but still have some illicit opioid use, right, some of the risks are a little higher, and we need to be careful about that. We have seen that with moving in, there is some anecdotal reports of mothers falling asleep with the infant, of near-miss infant falls. So there are important kind of balancing measures that we do need to think about that relate to some city. But those are the minority. Is that fair? But I agree with you that we do need to think better about measures that are mother focused. Yeah, we'll show you just a couple of subgroup analyses that I think reinforce some of the lessons we've learned from our overall analyses. The main take home from subgroup analyses is these elements of non-farm care, breast milk use, rooming in, avoiding an intensive care setting. They work, they're important, and they improve outcomes significantly. So here is a graph that shows length of stay in two subgroups. The blue line is those babies that needed pharmacologic therapy, and the red line is those babies that did not. This is fairly obvious, but it's important. Once you start on pharmacologic therapy, that is the main driver of length of stay. You can see that it's 20 days versus 5 to 6 days. These next two slides are similar. So this shows, again, two subgroups by different, the top graph looks at length of stay, the bottom graph looks at the need for farm therapy. So length of stay on the top, farm therapy on the bottom. And the subgroups, the blue line is those babies that received breast milk, the red line is those babies that did not. And so you can see in both of these measures, length of stay and need for farm therapy, babies who received breast milk had less length of stay and less need for farm therapy than babies that did not receive breast milk. Similarly, this is rooming in. So the same measures, length of stay on the top, need for farm therapy on the bottom graph. The blue line is those babies that did room in for at least one night. The red line is babies that did not room in. And babies, or you should say families that roomed in, had less length of stay and less need for farm therapy. This next one is a little trickier. This is looking at care in a non-intensive setting. So on the top graph, this is length of stay, where the blue line is babies that did get care in NICU or special care nursery. The red line is babies that did not. Not surprisingly, once you get into a special care nursery or NICU, your length of stay is much longer. That's largely driven by the fact that in many hospitals, once you start on pharmacologic therapy, by policy, the babies go into the intensive care setting. That's changing, but that was kind of an historic practice. So that top graph looks very similar to the farm therapy graph, because intensive care, needing intensive care is very similar to needing farm therapy. But in the bottom graph, this is among babies who needed farm therapy. So just among the ones who needed farm therapy, the dark blue line is being cared for in non-NICU or a special care nursery. The light blue line is being cared for in an intensive care setting. So even if you just look at babies who needed farm therapy, if you could manage them not in an intensive care setting, it appears to be associated with a real difference in length of stay. I mentioned that we wanted to kind of share with you some hospital-specific analyses. We're not showing the data, we're just giving the kind of highlights of this. But at all the hospitals, all the 6 hospitals, we saw interesting and additional work that those hospitals are doing that were important lessons for kind of spread. So Bay-State, they used the HBC money to build a full rooming in model, where they were able to commit a couple of rooms for moms to be able to stay as long as the babies were in the hospital, which can be, as you saw, days to weeks. And they saw that those families that were able to use that full rooming in model, they had fewer days of farm therapy and shorter length of stay, even among the infants needing farm therapy. At Boston Medical Center, which is for all these hospitals and leaders, BMC in particular has been a leader in this space for quite some time. They implemented a non-farm bundle that showed a lower length of stay and less need for farm therapy, even before adoption of what's called Eat, Sleep, and Soul model. You may, if you're interested in space, you may have heard about this ESC approach to care, which is kind of really shaking things up. So alternative way of thinking about these infants and symptoms compared to the traditional Finnegan score approach. BMC's work is important because while they have adopted ESC and they're helping many other hospitals with ESC, they showed that the ESC scoring tool is important, but it's actually the non-farm care part of ESC that's the most important. Lawrence General worked very hard at looking at cost savings associated with their improvements, and they saw a 35% reduction in cost. UMass Memorial Medical Center took our basic data measures and went one step further. They looked with regards to breast milk, that the amount of breast milk being received. And they not only saw that breast milk is protective, as we saw, they also saw a dose response curve, where the amount of breast milk these babies gets associated with improvement in outcomes as well. So overall conclusions, these are the numeric results, and I don't think I'll run through all of these, but on the maternal side, about 75% of these babies are born to moms in MAT. We're really excited by the improvements on the neonatal side, decreases in need for foreign therapy, need for care in NICU or special care nursery, and overall length of stay. Some improvements in non-farm care, although still some more potential there. And then at pre-discharge, we think there's some work to be done. So overall, non-farm care, family-centered care, it works. Breast milk coming in, not using the intensive care setting, all of those improve clinical outcomes significantly. The HPC hospitals, they made real changes to the care of mothers with opioid use disorder and their infants that led to significant improvements. But there still remain opportunities for further improvements almost throughout the whole period. We'll just mention that there's quite a few areas we're taking this work. Here are two specific areas to highlight that did show up in our data. We haven't shown you this data, but a couple kind of patterns that are interesting. So maternal MAT use as compared to maternal use of illicit opioids. Maternal MAT use does not appear associated with less severe NAS. So if moms are on MAT, the baby still can get NAS, and they still may need foreign therapy, maybe even at higher rates than babies born to mothers on illicit opioids. We still believe real firmly that the best course of action is to get those moms on MAT. If there's one thing we can do as a community, is to get all these moms on MAT. We just need to recognize that a baby with NAS is not a bad outcome. That could be a good outcome if it means that the moms are on MAT. We're starting to dig deeper into equity and disparities. The one way we can measure it in our current data set is by race ethnicity. We are seeing some trends, the numbers are small, but we're seeing some trends towards lower rates of MAT among mothers who are Black or Hispanic. And if this persists, it may suggest some barriers to accessing MAT with those populations, which anecdotally, we have heard similar anecdotes from providers who care for these moms. Perfect, thank you.
Great, thank you. I'll wrap up briefly, only because I want to get to any other questions that the commissioners have, but what you can expect, and I anticipate that you're probably as excited as I am to see where some of these the analysis continue to go in the second year of studying. We also have, in collaboration with our partners at DPH and through their evaluation of the moms through care initiatives, a mother-focused evaluation, and especially where the commissioner, you wisely asked about what are the barriers to these mothers being able to participate in this care, and oftentimes it is not barriers that they themselves present, but the barriers that are presented in the hospital when they try to be participants in their baby's health. So much of that is very important, and we are eager to speak about that after the end of the full period of performance for our all 6 initiatives, including our 2 moms through care replication sites. So anticipate bringing more of that to you here later this year. Please, any questions for that?
Question I have is, and just let me go back to
critically important, and you're right, I think Massachusetts is, through DPH, through your Chapter 55 project, you showed this, you showed that post-discharge period is this critically high risk period for these moms, both for relapse as well as unfortunately for maternal deaths. We need to get to that space. Right now our data system is built for hospital-based data. We are actively exploring ways to include follow-up data. 3 months, 6 months, even a year. Our main measure there currently is from early intervention. We're looking at ways to partner with the pediatric community. Like you were suggesting at the end, it might be that focusing on baby outcomes is a good marker for maternal outcomes, just because the babies are more captured. They're seeing pediatricians, the mothers, they may or may not be kind of still captured in the healthcare system after the first postpartum visit. So if we can partner with the pediatric community to tie our data system to data on how the kids are doing in 3 months, 6 months, 9 months, 12 months, whether they're with the family, whether they're in EI, that might at least give us some kind of marker of continued maternal compliance with MAT, continued maternal health and wellness. But you're right, that post-discharge piece is critical. I think that there's every reason to believe that if we improve our inpatient care in terms of family-centered care, and we get the families more involved, we get higher breastfeed rates, we get more women in, we get more of these babies going home with biological moms, that will kind of increase chances of mothers staying compliant with drug therapy and staying healthy. There's lots of reasons to believe that, but we don't know that yet.
Yeah, I think that this is probably a helpful time to make a plug for a future program that we're working on. We were allocated around $500,000 to develop a program for substance-exposed newborns, a broader term, right, than just newborns with opioid exposure. That's a bit more longitudinal, so really will be focused more in a pediatric setting and thinking about the mother-child dyad, a little bit more so than the MAS interventions, which are more focused on the baby outcomes. The language is quite longitudinal. It's up to age 18, but I think with the funding that we have, we're exploring options with a number of really innovative models, which are actually able to care for the mom, the baby, and mom's partner in some cases in the same setting, and be able to do mom's MAT and her primary care and her obstetrical care and pediatric care. So some really innovative models that are out there in Massachusetts right now with BMC and MGH, and we'd love to see how we can use our funding to scale and expand that, and potentially add to Munish's absolutely amazing database.
And I would just add, I think, important to have the data to prove this out and to really understand. I think that's what Kate's speaking to, is how we can get, beyond 3 to 6 months, maybe 2 years, 3 years, and think about how to build something like that. But, anecdotally, one of the things that we know from going to these hospitals and working with this is that a lot of this work also was around destigmatization of the mothers and these infants, and training the clinical staff in these hospitals to really, double down on compassionate care. And I have to think that if people are interacting with the healthcare system and having a more positive experience in this really critical moment, as opposed to feeling ostracized and alienated and judged, that does feel to me like could be an intervention that could change some of these longer term outcomes. I don't know if that will bear out, but certainly we hear that from the clinical staff and from these patients and mothers about how it feels different in terms of their interaction with the healthcare system.
A question and then a thought. After the evaluation summary is done, which looks as though you're projecting a little time, what happens next? You have some important information to share. What do we do with it? How do we get it out there? What's our role? And it's my continuing orientation to understand the role of the commissioner, but from my public health background, I can't wait to get my hands on this and do something with it. So
why don't I speak to it from the commission's perspective, and Munish would love you to speak to it from the clinical community perspective, because he really, I don't know if we mentioned it, he is a neonatologist, his partner is an obstetrician. I think you need your pediatrician trio to add out your trio, but I think there is work to be done in sort of clinical quality improvement, and then there's the Health Policy Commission's role, which is broader, and we do have a sort of a learning and dissemination agenda where we like to share these really important results, share tactically how the clinical teams and the non-clinical teams who for that matter, are doing this work in kind of a easy to understand, not clinical way, for a broader audience than just providers. But we do that through meetings, we do that through policy briefs, we do that through webinars. We have a pretty robust set of tools in our toolkit to share the information. I think publishing is also for results like this a very clear way to get it out. But Manish, you want to speak to how you do this through PinPin?
Definitely, thank you, and great question. So PinPin, like, we're collaboratives, statewide collaboratives, and while the HBC work has been a big driver of what we're doing, from the get-go we have been focusing on spread and sustainment. So currently, out of about 45 to 48 hospitals that touch moms and babies in the state, there's probably around 35 to 40 that are within our collaborative, 25 that are sharing data, but another 10 to 15 that come to our meetings, come to our summits. So we've been doing these summits for a couple of years, these twice-year meetings that Griffin mentioned. We are committed to continuing those. DPH has been a partner of our collaborative for a number of years, and various agencies within DPH have supported us as well. So these summits we imagine will continue for at least another 2 to 3 years. That'll be an important venue for spread. The database is going to continue. I cannot imagine any of the 6 HPC hospitals will stop collecting data after this project ends, just because they've been committed to the space for years before HPC, and I'm sure they need to remain committed for years after. So our collaborative continues. The HPC, we are talking about some more HPC support that could kind of help us do even more things in the future, whether it be expanding the data to post-discharge data or new learning techniques, new measurement tools that we could use. But the basic collaborative will continue. On that note, Griff mentioned our next summit is June 11th. It's these meetings are exciting meetings. They fill out pretty quickly. They expand the capacity each time. I think this time we'll get up to 400 people in the room, and it will fill out. Hospital teams come, DPH folks come, community organizations come, families come. Some of the families will be sharing their stories, and it's an exciting meeting. So we'll continue this work, and I think you're right. We've been thinking about spread already, and it'll be a focus moving forward.
And Munish, can I give one last plug to the NeoQuick website, wherein you host for the collaborative and for anyone interested in doing and replicating this work, a series of videos, tools, screening checklists, nearly everything except the people to do it, to do this work, including for the ESC scoring methodology, which we're continue to host a very collaborative for on a regular basis.
Great work. I'm going to channel the committee that was here earlier. You mentioned Lawrence General, so 35% cost decrease. Have you seen that across the other sites as well? A similar savings across other sites?
So one of these folks maybe was because we have not been measuring costs as part of our data system, like the reduction in length of stays across the board, the reduction in ICU cares across the board, so I'm for sure those have cost savings, but we have not measured that ourselves.
Something to consider down the road. My other question, I'm struck by your last slide, and from a health equity point of view, the barriers to treatment for Black and Hispanic women for MAT. Any hypothesis there on what's going on?
Yeah. So I will tell you what others have told me. Unfortunately, I'm a neonatologist, so I'm not seeing these moms well before they get into the birth authorization. Two things. One, our numbers are so small. So among these 1,200 babies, the significant majority are white families. So our numbers of Black and Hispanic families is so small. We're seeing these differences, but we need to see if they pan out. But when we shared this at our last summit, numerous mom providers did comment that there are hints of stigma, of social pressures within those communities that may limit those moms from seeking treatment, that whether it be within the Hispanic community or within the Black families, for whatever reason, there's still more of a stigma that prevents those mothers from engaging in the healthcare system. That's anecdotal.
Any other questions? Thank you very much. Great work.
David, next meetings?
again, just want to highlight that our next meeting will be our hearing on the potential modification of the healthcare cost growth benchmark, March 13th at the State House right up the hill. If you are interested in testifying, there's contact information here. But I hope to see you all there for a great conversation and testimony at this newly redesigned Gardner Auditorium at the State House.